Hi, my name's Amanda. I am a childbirth educator here in Washington State and also a member of the International Childbirth Education Association and mama of two. I have two 3-year-old little boys and recently delivered a baby via surrogacy for another family, and she is now 4 months old. So I've been in your shoes. I've done this before. I know how exciting but intimidating it is, and I want to be able to relieve some of that anxiety and make this a happy experience for you with knowledge and tools for a positive birth. I also graduated with a bachelor's degree from Washington State University in basic medical science and have a minor in human development, and also have some work experience doing maternal fetal medicine research. So bring some education to the table as well, and would love to answer any questions that you have. And so let's get started. In this class, we're going to talk about a variety of material. We're going to talk about anatomy of pregnancy and birth, a little bit about prenatal nutrition and how that can affect your birth in a positive way. We're also going to talk about the stages of labor and what those look like, when to go to the hospital, what to bring with you, how to manage your pain when you're at home before it's time to go to the hospital. We are going to talk about creating a safe birthplace and why that's important. We are going to talk about labor coping skills, pain management, both naturally and with medicated options. We're going to talk about natural and medical interventions for augmentation. We're also going to talk about the types of birth that are available, both vaginal and cesarean, and within those categories, unmedicated versus medicated, water birth. We are going to talk about a variety of coping skills using relaxation methods, touch, aromatherapy, hydrotherapy. We are going to talk about partner support and why it's so important, and how that can aid you in having a positive birth experience. We are also going to talk about birth plans, why it's nice to have one, but why it's also important to be flexible with that and recognizing that every birth is different, and that we need to be open to what's best for our bodies and for our babies, and stick as close to our birth plan as possible, but to be a little bit open to some flexibility. We're also going to talk about newborn appearance when your baby first gets here. We're going to talk about what to expect, what's normal, what's maybe not normal, what types of procedures they're going to offer you to your baby when he or she first arrives. We're going to talk about newborn care and touch briefly on postpartum care and breastfeeding. Although we do recommend that you take a specific breastfeeding course by somebody who's IBCLC certified. So the intention of this course is to be a brief overview of all of the tools and resources that are available to you to make this a positive birth experience, because this is a big day and this is something that can be really exciting and a really great bonding experience for the entire family. I like to start the class by separating the pregnant women from their partners and having each of you come up with a list of some of the joys and some of the maybe challenges or fears that you have around the birth experience. And I have you do this because I want you to get excited. Let's talk about the joys. But I also want you to identify what you're most afraid of, because that is when you're going to need the most support. And I want your partner to be equipped with the right tools and the correct coping mechanisms that are going to be most effective in those scenarios that you're most stressed out about. And for some reason, I seem to see the pregnant women are most afraid of the actual pain of birth. And then the partners seem to be most afraid of what they're going to do with this little guy when they get home for the next 18 years. So it's kind of fun to see the differences between the two. So I encourage you guys to talk about them after this class. And then also practice what we learn at home and figure out which mechanisms for coping are the best for you. I also encourage you to take some sort of after baby or becoming us class. And the reason for that is because most relationships experience some level of dissatisfaction after having a baby. And this is usually due to nothing personal, but that your roles are changing, your expectations of each other in those roles are changing, your level of sleep and exhaustion is changing. You're also, maybe there's some financial stress or some, balancing your time and work and school and time with the baby and time with your husband, just your priority shift. So learning how to communicate and maintain a strong bond through some of those post-baby challenges is really helpful. So those can be some stresses too that I encourage you to seek further support on after the baby is here. Let's talk about the anatomy of pregnancy. So I have a diagram here of what your body looks like pre-baby, and this diagram is about 34 weeks pregnant. And what I really want to point out are some of the differences here. So obviously the baby is taking up the majority of the abdominal cavity. This was putting a lot of pressure on the intestines. Look how much room you have over here. And over here, they're all squished up. That's explaining why you're having maybe some heartburn or morning sickness, constipation, other types of digestive problems while pregnant. Also, if you notice that the lungs are a lot more squished when you're pregnant, this is why you're having shortness of breath walking up the stairs, and a minor exercise might be putting you out of breath. Also, if you notice that the majority of the baby's weight is sitting right on top of the bladder down here, versus having lots of room when you're not pregnant. This is why you have to constantly pee. It gets worse as the pregnancy goes on. And that's actually, we have a diagram here of when you're about 40 weeks pregnant, and you can see how squished this cavity is. This is why when you feel like you have to pee really bad, and then you go pee, and it's just like barely a trickle, because the baby's kind of putting a lot of pressure, cutting off that bladder a little bit, and so only a little bit comes out, and then when the pressure is relieved, this little bit of urine over here slides back down. Now you feel like you have to pee again. So you're constantly having to pee because your bladder can only fill up so much because of all that pressure from the baby's weight. And then also, if you notice, we have this cervix is very thick here, and there's a little plug of mucus, and that'll come out towards the end of your pregnancy. It's not necessarily a sign that you're going into labor. We'll talk about signs of labor later, but this mucus plug will eventually come out. It also, this is your cervix here, and the thickness of it, this direction, is called effacement, and then this direction would be your dilation. So as it gets wider, you're dilating, and as it gets thinner, you're getting more and more effaced. So if somebody says, oh, you're 1 centimeter dilated and 80% effaced, it means you're on your way to getting towards the end of this pregnancy, but that you're not necessarily in labor yet. So again, we'll talk about that in a little bit. I also wanted to point out the weight of this baby pulling forward on the end of your sacrum or in the end of your spine, causing some of that lower back pain that mom might be exhibiting. Also, if you look at this diagram that we have here, this is also 40 weeks pregnant. And what you're going to notice here is these round ligaments that are on the side of your uterus, and that is the weight of the baby can pull on those, and that's why sometimes when you're sleeping and you turn over, you can experience some side pain, and also where they attach here to the back of the sacrum. That's why you're getting some of that low back pain while sleeping. So partners, be understanding. This is why mom is so uncomfortable and might be a little bit grumpy. So just bear with us. There is a light at the end of the tunnel. Just being aware. And also here in the breast, we're going to see that there's some engorgement here as those mammary cells grow and get ready to make milk for the baby. And you might see a little bit of colostrum coming out towards the end of your pregnancy, and this is totally normal. It will turn to regular milk later, and we'll talk about that when we get to breastfeeding. The final thing I want to point out about the anatomical diagrams is the size of your uterus from when you're not pregnant to when you are pregnant. It goes from the size of your fist all the way to the size of a human child, and it becomes 40 times larger than its pre-pregnant state, making it the largest muscle in your body during that time period of being pregnant. So understand that this is why you might be a little bit crampy, and also why you are so capable of doing this, because the largest muscle in your body is going to be contracting on this baby. There are a couple really important hormones that I wanted to talk about that play a significant role in pregnancy and labor. One of them is relaxin. Relaxin is a hormone that is released that causes the cartilage in your body to kind of loosen up a little bit. And that's really important for when we have our pelvis and we want it to kind of have some flex during birth in order for that baby to be able to move around and get down through the birth canal. And that's why we promote the squatting position so much, because it can open the pelvis as much as 20% due to this loose cartilage, which is also why your hips are probably popping out of place, or maybe you feel discomfort in your ribs when you're sleeping, because all the cartilage that's holding those bones together has been kind of loosened a little bit in the weeks and months before the birth process begins.
Also, we have oxytocin and adrenaline, and these hormones are especially important. And oxytocin not only starts labor, but it promotes the continuation of labor through a positive feedback mechanism in your body. So, meaning the more oxytocin that's released, the more it triggers your brain to, to send more. And what happens is that adrenaline very much counters that. And the reason that we see that back in the caveman days is because when an animal was just to like go into labor, you're in this very vulnerable position, and the body needed some type of hormone or mechanism in order to pause or stop labor so that the animal could relocate itself to somewhere safe, maybe in the presence of a mountain lion or something like that, stop labor, get somewhere safe where it could resume labor again in order to preserve the continuation of that species. And so we still have this balance in our body. And so that's why we want to promote all of these oxytocin releasing activities, cuddling, nipple stimulation, going on a date in early pregnancy, maybe a relaxing bath, and your partner is there just, rubbing you, and you're promoting this closeness and this love release of oxytocin. Then what we are trying to prevent during labor is things that cause you to be scared, whether those things be pre-existing fears that you have around the birth experience that you've been taught culturally. Maybe they are just your body's natural reaction to pain sometimes. Maybe it's the fact your mother-in-law is in the room. Maybe your mountain lion's your mother-in-law and you just really didn't want her there and you're feeling nervous or anxious or insecure about that. This is your time, and it's okay to remove those sources of fear because they are inhibiting the progression of your labor. And so we want to kind of lessen that in early stages of labor. Once it becomes the pushing stage, having a rush of adrenaline can be a good thing because it's giving you that, like, let's do this, let's fight, right? Not the flight that you get originally, but the fight that adrenaline gives you. And so that's okay once we're like so far into this that there's no turning back. And that hormone can be useful then. But again, oxytocin and adrenaline are very important, and being able to regulate those throughout your labor is really important.
Let's talk about nutrition during pregnancy. And I'm sure if you haven't already experienced this, it's probably coming. Being pregnant is like the only time in your life when it apparently becomes completely okay to talk about other people's weight. And so you'll have lots of people come up to you and say, "Oh my gosh, there's no way you're only 20 weeks. You look like you're 35 weeks." Like, "Do you think?" Or the opposite, and they're like, "Oh my goodness, you were 35 weeks. You look like you're, just barely pregnant. Have you been eating right?" And so everybody's going to comment on your weight during pregnancy. And there's a really wide range of normal here on what's acceptable. They say the average is like 25 to 35 pounds that you'll gain during pregnancy. And that can be different for a variety of different reasons. I have one friend who, the first pregnancy, she ate like not very well. She didn't exercise at all. She gained 50 pounds. The next pregnancy, she was like, I am going to do this right. She ate super healthy. She exercised all the time. She gained 50 pounds. That's just what her body did while pregnant. For me, I had morning sickness so bad, I started losing weight before I ever gained weight. So, that affected my numbers as well. So there's a wide range of normal here. And let's not focus as much on the weight gain as you should focus on the nutrition that you're getting. So getting adequate protein is really important. You're going to need like 60 to 100 grams per day. And the reason for that is because you want protein in your blood in order to help with circulation to prevent preeclampsia, which is a blood pressure problem that some women get while pregnant, and it can be severe. So you want to take every precaution we can to prevent things like that from happening. Also, you want to focus on getting enough protein in your blood because if you don't, your blood becomes kind of watery and it can cause interstitial problems. Also, you want to focus on getting enough iron in your blood. And some people can do this through diet alone. Some pregnant women need supplementation. So talk to your healthcare provider about what is necessary for you in your body. If you do require iron supplementation, your healthcare provider will probably recommend that you take it separate from your prenatal vitamin. And there's two reasons for that. One is that calcium can block the uptake of iron, and most prenatal vitamins include calcium in them. So making sure you take your iron supplement separate from your prenatal, and also not while consuming some sort of
dairy products. I don't take it with milk or other calcium-rich foods. And the other reason for taking it separate from your prenatal vitamin is because my healthcare provider recently informed me that there have been studies done that suggest that if you were to take iron every single day, you're getting an overload of iron and your body will shut down its ability to absorb this iron. So they want you to take it every other day in order for your body to regulate it properly and get the complete absorption there. So again, you want to be taking your prenatal vitamin every day, but your iron every other day. And so taking them as separate supplements is important. Some signs that labor is near or coming. You could have some Braxton Hicks. These are kind of like pre-labor contractions. They are often felt more in the front, whereas true labor contractions kind of start in the back and move forward. And then also Braxton Hicks kind of come and go. They don't change with time, meaning that they get more and more strong or closer together over time. They kind of come and go, or maybe you have them for even maybe a couple of hours regularly, and then they just completely stop. And they can have days between them, kind of thing. But this is a good sign that your body is starting to get ready. And the point of these contractions, it's kind of like a workout. You don't just go to the gym and lift 300 pounds. Like you train those muscles to be able to do that. And Braxton Hicks are kind of like training contractions. They're building the strength of that uterine muscle. And that's important because the uterus has these kind of vertical fibers that pull back and they pull back and they retract like that. And it opens the cervix as they pull back. And there's also some circular fibers that go around it this way. And those ones are not the involuntary retraction. We have a little bit more control over those particular fibers. And that's why it's so important for us to learn these different birthing techniques in order to be able to help our body and aid it in doing this the most efficient way possible, staying calm and pushing with contractions, that kind of thing. So helping our uterus control this birth experience. Another sign that labor is near could be what we call lightning. So lightning meaning or people will say the baby dropped. So sometimes this just kind of maybe happens when you're sleeping, or maybe it's not necessarily like all of a sudden your bowling ball just drops in your belly, but you do kind of feel like lighter. And because the baby right now is like up in your ribs, up and pushing on your lungs and your intestines. And when the baby actually descends into the pelvic region or into the pelvis, all of a sudden your organs have more room and it does feel lighter, and maybe you can eat a whole sandwich now instead of your normal half or whatever. And but you'll start to see women kind of get like a little waddle when this happens. Another sign that labor could be near, if you're not losing a lot of weight, that you should see a doctor if that happens. But sometimes your body just starts to eliminate in order to make room for the baby. So can also be another reason that women will get diarrhea just before labor, or maybe not diarrhea, but frequent poop, or they find themselves peeing even more than usual because their body is eliminating all of the fluid or that solid material in order to make more space in the pelvic cavity. So this is actually like a super awesome thing that you're going poop a lot right before labor. And I also bring this pooping topic up because a lot of women are afraid that they are going to poop in labor. And because the muscles that you're using to push are very much like the same and all connected for the muscles that you're going to be using to push out this baby. And so if you're really worried about it, my tip is to you to go to the bathroom as much as you can before you go to the hospital. Just if you're at home, try to poop as much as you can during early labor. Believe it or not, it makes more room, and getting those muscles moving and practicing actually helps, because when it comes time to push, it's going to feel very much like that. You're going to feel this urge to push, and it's going to feel like you have to go poop really bad. And you know what? If it happens, it happens. They're going to tell you didn't anyway, so don't even worry about it. And actually, speaking of the urge to push, I continually felt this strong urge to push when I was in active labor, but not at transition yet. In fact, the whole drive to the hospital, I kept feeling like I had to push. And when I got there, they said, "You're a 6." 6 centimeters dilated, do not push because your cervix isn't open yet. So they don't want you to push and tear the cervix. And they said the fact that it was painful when I would push, they said that means you're not ready yet, because when it's truly time to push and you push, it should be semi-relieving. The whole process is uncomfortable, but that it should not be a painful pressure on your cervix. The baby should be descended and ready to come out when you start pushing. And so that's kind of a way to know too what stage you're in, if pushing is hurting versus not hurting. And anyway, so also another sign that labor could be near would be if you are experiencing nesting type behaviors. So maybe mom all of a sudden is like cleaning everything, or she's getting super organized, or she wakes up in the middle of the night and she just has to wash all the baby's clothes. Baby's not even here yet. Or, just these particular like innate tidying tasks where you're building you're nesting, you're building your nest for this baby to come home. This is biological. Even as a surrogate, when I was not bringing a baby home, I did not have a nursery to get ready, didn't have any baby clothes to wash, so I didn't have to prepare my life for this newborn infant. And even then, all of a sudden, I started cleaning. I've never been so organized in my life. And it was like I just had to do it. And I kid you not, I had the baby a week later. So, in those days and weeks before labor, mom might start to like do some crazy cleaning. Just embrace it and, offer to help out and know that the time is coming and, get excited.
There are 4 stages of labor. The first stage is a period of effacement and dilation, so the time that it takes your body to go from 0 to 10 centimeters in dilation. So again, that cervix widening out, and the effacement is the cervix thinning down. So again, 0 to 10 centimeters. And of that stage, there are 3 phases. So you have phase 1, which is 0 to 3 centimeters. It's called the early or latent phase, categorized by about 30 to 45-second long contractions that are about 5 to 30 minutes apart. And then the second phase being active labor from about 4 to 7 centimeters, contractions lasting about 45 to 60 seconds, about 5 minutes apart. And they're going to grow closer and closer together over time and become stronger and stronger. And then we're going to have transition, which is that third phase of the first stage of labor. And that's from about 8 to centimeters to complete. So complete dilation meaning 10 centimeters dilated. And that's when the baby, you're going to be able to start pushing. So that transition phase, and it'll be characterized by contractions that are typically 60 to 90 seconds in length, and they're about 2 to 3 minutes apart. So we'll go a little bit more into detail on each of those individual phases. And then the second stage of labor is from when you're 10 centimeters dilated to when you deliver your baby. And then from the time you deliver your baby to when you deliver your placenta, that's stage 3. And then after you deliver the baby in the placenta, your uterus is going to shrink down in size. That's called uterine involution, and that's stage 4. The majority of uterine involution, meaning percentage of it shrinking down, happens while you're a couple days after, but mostly while you're at the hospital. But this process can take up to like 6 weeks. So that stage 4 is actually pretty long. But let's start talking about the first phase of labor, of that early labor period from 0 to 3 centimeters, what to expect and how to cope. During the first phase of labor, it's a good idea to get as much rest as you possibly can, take a nap, also store up your energy, eat some snacks, and drink a lot of water. You're preparing your body to do something that is a marathon. So get your energy in now, especially if you plan on getting an epidural later, because after you get an epidural, you won't be allowed to eat any food at the hospital because it's an anesthesia risk. And so making sure that during this early labor phase when you're at home and you're laboring and contracting, to get that energy reserve started now. Also, it's a good idea to do some activities that promote oxytocin flow. So cuddling with your partner, watching a movie together, and maybe a light massage. things that make you feel warm and connected, that promote the labor to continue, because oxytocin is what causes uterine contraction, and oxytocin is also the love hormone that gets released when we feel safe and nurtured and loved. And so going on a light date, and just spending some time together, playing games, things to distract yourself from the discomfort of the contractions. They won't start out excruciating. They will start out as this kind of mild cramping pain, kind of similar to PMS. So just distracting yourself away from that. I initially made the mistake of thinking that my contractions were constipation pain. Because constipation is really common in the end of pregnancy. And so I kind of thought that that cramping was, because it was in my back, I thought that it was due to constipation. It was in fact not. And so I had taken a whole bunch of fiber gummies thinking that this was an issue, and just what everyone wants to take before she has a baby, something to make you poop extra. So anyways, it can feel like that, feel like PMS. And they will get progressively worse, but they are distractible in the beginning. And that's a way that you'll know that you're sort of transitioning into the active phase of labor, that you all of a sudden, you can't just go on a date. You can't really talk and cuddle. Like, you're not distractible anymore because the pain is getting stronger and stronger, and it requires more mental effort to cope with. And that's kind of how you're seeing that transition happen. So at first you're distracting, partner is able, you kind of giggle, you have fun through it, you take a couple seconds to breathe, but you can get through it, and then it's going to get harder. And as we make that shift into active labor, there's a whole new set of coping mechanisms that we can use, including hydrotherapy, aromatherapy, massage, different positions that can help alleviate some discomfort, doing visualizations and relaxation type exercises. So we'll talk about all of those in a minute. One last thing I wanted to mention though about the early phase is that there are some things that can speed it up and some things that can slow it down. So one of the things that can speed up early labor is having sex or drinking like red raspberry tea. So you'd want to talk to your healthcare provider about those natural augmentation methods. But the reason that having sex during early labor can speed things along is because sperm acts as a prostaglandin, and it eats away at the cervix and thins it out, so labor can progress quicker. Red raspberry tea is also a prostaglandin. And then also the other benefit to having sex during this early labor phase, if it's not too uncomfortable for you, is that it promotes the flow of oxytocin. So you're feeling close, you're feeling nurtured and loved, and this exciting thing is about to happen, and it's a lovely experience. And oxytocin is the hormone that your body releases when it's in love, but it's also the hormone that your body releases that causes uterine contractions. And so it can promote that continuation of labor in that way. And also something to consider as far as hydrotherapy goes during early labor is that although water can be very relaxing, which is why we recommend that as a coping mechanism in active labor, it can be so relaxing that in early labor, it can actually kind of cause your contractions to peter off. So you get in the tub and it kind of relaxes your uterus, and we can see those contractions kind of stop for a while. And sometimes when you think that you're in labor but not quite sure, that's one way that they might have you test. If you called your provider on the phone, to be like, we'll get in a warm bath, and if it doesn't stop, then it's time to come in. But your water might break during this early labor phase, and your water breaking is always an indication to go to the hospital, even if you're not experiencing contractions yet. And the reason for that is because once your water breaks, you're on the clock. You need to have your baby within a specific time frame so that you don't introduce any kind of bacteria up into the amniotic sac where the baby is. So there's a reason they want you to go to the hospital once that happens. And Ways to tell, did my water break or did I just pee myself yet again? We want you to look at the amount of fluid that's coming out, in the odor of the fluid, the color of the fluid, and these can all kind of help you determine whether or not this is true amniotic fluid or if it is urine. So urine smells like urine. Amniotic fluid will have a sweeter smell to it versus the acidic smell of urine. Um, and amniotic fluid should be clear in color versus urine, which is typically yellow to clear. If you're really hydrated, both will be clear. So again, smelling it can help. Also the amount. So usually if you pee yourself too, it's like a one and done kind of thing. Like, oops, I peed myself. Amniotic fluid will continue to leak. Like it won't, it's not just going to stop. And I guess that's not always true. Sometimes there's a little rupture in the membrane, and then the baby is sitting so low, its head kind of like corks it, and so then it'll stop. So, what we want you to do is to keep moving around. Try some different breathing ball positions or kind of move around, maybe do some squats and see if any more fluid comes out. Because if you just peed yourself, chances are that it's not going to continue to flow in different positions. But if we kind of get the baby moving in the baby's head, if the baby's head was in fact corking um, that ruptured spot, then the fluid would continue to leak out some more. And I'm pointing this out because sometimes it is a slow leak. It's not always this Hollywood gush of fluid that just like splashes all over the ground. And for some reason, all these women are always wearing dresses when this happens. It can, in fact, feel like you just wet your pants. So we want to encourage you to go to the hospital if there is any kind of leakage of fluid, just to make sure that you're not, starting early labor. There's a great acronym for remembering what to do if you think your water might have broken, and that's TACO, T-A-C-O. T for noting the time that the rupture occurs. A, noting an approximate amount. Not that you need to get out your, measuring cup, but just, it was a lot or it was a slow trickle. C for color. Again, we talked about whether it's yellow or clear. I forgot to mention that it could even be a little bit brown. If you're in early labor and you've been contracting, sometimes babies get slightly stressed out and they release, like, it's called meconium. It's like baby poop. Doesn't have bacteria in it like what our poop has in it. So don't be concerned for the baby breathing that in. It's just that it can be a signal that the baby is stressed out. So if it comes out kind of brown, that means there's probably meconium in it. And that would be something to note to your healthcare provider as well. And then again, the odor. So does it smell like urine? Does it smell sweet like amniotic fluid? Does it smell kind of stinky like meconium? So that's the acronym we want you to remember, TACO, TACO. Let's move on to the second phase of the first stage of labor. This is the active phase. This is when we know it's the real deal. This is when we talked about the 5-1-1 rule. So contractions are going to start to be about 45 to 60 seconds in length, happening approximately 5, maybe less minutes apart, and they're going to continue to get stronger over time. So mom is going to need a lot of support, a lot of encouragement. This is a great time to implement some of the coping mechanisms we're about to learn, and is also a time that we're going to discuss pain management options. The coping mechanisms that we're going to discuss are applicable for both medicated and unmedicated births. And so I want everybody to pay attention and try these things at home, even if your plan is to do an epidural right when you get to the hospital. Sometimes things don't always go to plan. And if the anesthesiologist is in the middle of a cesarean, or if there's somebody who's in front of you in line for an epidural, or maybe you have a really precipitous delivery and you maybe don't have time to get one. And I don't say those things to scare you, rather that I just want you to be prepared. Don't offset these coping mechanisms and skip past this section because your plan is just to get an epidural, because you want to be prepared for anything. And you also don't usually get an epidural until you've moved into more active labor, or until they're really seeing that progression of contractions. So you might need some of these in early labor while you're still having contractions, but maybe they're not close enough together for the hospital to agree to give you an epidural. So again, These are important skills, and you can use them throughout all the rest of your life. I use some of them as a parent. The breathing exercises when my toddler is being crazy have been very helpful at times. So I encourage you all to pay attention. I want to talk about some breathing techniques first because I think that anytime you're doing any kind of physical exertion, working out, birthing a child, it's important to deliver oxygen to your muscles so that they have the strength to carry through with whatever that action, or in this case, contraction, is for. And so taking deep breaths is really important. It also helps to calm you a little bit. And it doesn't always come as naturally as you would think it would. I was very naive when I was younger and thought that, this is so natural. I know how to deep breathe. I got this. And then it quickly went from to, and my boyfriend jokes that I was spitting on him the whole time that I was delivering this baby. And the reason I point that out is not to make fun of the type of pain that you're in or your breathing style, but to explain that shallow breathing that is uncontrollable is not necessarily the most effective or beneficial to you. It's really great when you have a pattern to focus on. And if you get to the mental state or the pain level where you can't necessarily self-regulate or control your breathing very much, it helps to have a partner who's also trained on these breathing techniques and patterns who can say, hey, you know what, Amanda, match me. Watch me breathe and breathe with me, breathe with me. You got this, breathe down this baby. And just be able to coach you through that. So let's talk about the first one would just be some regular slow breathing. We go in, 2, 3, 4, out, 2, 3, 4, in, 2, 3, 4, out, 2, 3, 4. So practice that one with your partner a couple times. Change the pace a little bit depending on what your lung capacity is. And then if pain gets a little bit more intense towards the end, it might be harder to take those long, deep breaths, and you might escalate very quickly to the type of breathing I implemented in the end there. But what would have been more constructive would be to change up the pattern a little bit. So you can do where there's he who, and that it distracts you a little bit because you have to remember to go back to the he after the who kind of thing. And so that type of pattern, that a b a b, it requires focus, and it's a slight distraction to be able to focus on that. And then sometimes when you're at complete, they might want you to do what they call laboring down. So they're gonna, even though the baby is there and maybe the baby's crowning, they might ask you, don't push with this contraction, and they kind of want the baby to kind of slowly press on that birth canal. And especially if the baby's crowning, they're trying to prevent tearing. So they're letting this slow, gradual descent instead of a strong push. And so during this, you could still be exhibiting some pain. Some people call it a ring of fire, or maybe it's just a lot of immense pressure for you. Either way, if you're going to resist a contraction while the baby is coming out of the birth canal, it's a whole nother kind of breathing, right? And so sometimes they'll have you just pant in order to kind of resist that urge to push. And so that can look like, or sometimes they have you do a little bit more shallow than that, and they'll have you stick your tongue out, or, do a little bit different of a pant, like very much like a dog, in order to get a little bit deeper, but keep the quick pace of it. So again, I encourage you to look up a bunch of different breathing techniques, figure out which ones you're comfortable with, and get used to it, so that this isn't your first time trying a breathing technique when you're in immense pain. You want it to be something you're familiar with, because it's a lot easier to remember than it is to learn when you're in a state of pain. Speaking of air in the room, one thing that some women choose to use for relaxation is aromatherapy. So, keeping some kind of candle warmer or an essential oil diffuser in your room can be relaxing. Not all hospitals allow this, so definitely check with your specific hospital. A lot of birth centers do if you're doing a home birth. Of course, that would be okay. And this is the one that I use. It's called Pure. Um, you just fill it, there's a little line in here, and you fill it with water. There's a lot of different smells. I would probably try something that's a little more gentle, and I would only start with like a single drop, just because once a smell is in a room, it's hard to get it out of a room. And so if it's too much for mom, or she thought she would like it and she doesn't anymore, of course remove the diffuser or the candle. um, but it's still going to be lingering, so maybe start small before making it more intense. I really like peppermint. I think that it doesn't have as many allergic reactions for other guests or people that you might have in the room, and it's still pretty relaxing, helps me get those deep breaths in. So again, aromatherapy is a great option for a lot of people. In active labor, mom might find herself having a hard time regulating her temperature. Maybe she's getting really hot, or you might see her shivering. That's actually not usually a sign of her being cold, but rather a sign that things are progressing and that her body is releasing a large amount of hormones at once, which can kind of cause this shaking or shivering symptom. It can also be a side effect of an epidural. So don't necessarily run to mom with blankets if she starts shaking. Ask her if she's cold. In fact, she might want the opposite, which is a fan. And a lot of women find it very relieving to have a little bit of airflow or circulation right next to their face. Having a handheld, either manual or electric fan can be really great. If she doesn't necessarily want it right close to her, getting one that plugs into the wall, the white noise can be relaxing, but also just getting that airflow through the room circulated can be a little bit more comfortable for mom. Another thing that mom might find relaxing in labor is a heated rice pack. I make mine at home. I just get a really long sock. I put about 2 to 3 cups of rice in it, and then I tie it off at the end. These are great. They're washable. You can pour the rice out, throw it in the washer, bring it back, pour the rice back in it. You just heat it up in the microwave for about a minute or however much mom likes. Maybe she wants it less hot or a little bit more hot. Most rooms will come with a microwave. Sometimes labor and delivery rooms do not, because a lot of women aren't able to eat during labor. So you'll probably have to go down the hall to like a patient nutrition station and use that microwave. Again, the nice thing about these types of rice heated pad versus an electrical heated pad is that it offers temporary relief, and the heat application is short term. So it will eventually wear off, usually shortly after your contraction is over, versus an electrical heating pad that is plugged in and a constant source of heat, because moms often overheat during labor, and so having a constant heat source could be the opposite of relaxing if you're starting to get hot. And also, these can be nice like stress balls, kind of. You pull on them when you're having a contraction, or maybe it's just a nice distraction to play with. So they're great in that way too, and you don't have to find a plug-in, so that's another benefit. So having one of these on handy, it's an easy thing to throw in your bag, and it's an easy thing to keep at home after baby for a relaxing moment of warmth as well. Another thing that moms oftentimes find comforting during labor, I know I did, was touch or massage therapy. Some people are able to have hospitals that or birthing centers that have a massage therapist on hand. Your partner is also a great asset to you in this moment, especially if you're not really comfortable with a stranger in that situation, and you prefer your partner to be the one to rub your back, or even like a full body massage, just kind of releasing that pressure from your shoulder all the way down your body, down your legs, and just focusing on moving that pressure, moving that energy, dispersing the pain away from your body. Um, I really liked using this coconut and hibiscus oil. There are lots of different kinds of massage oils. This one just wasn't such a strong flowery smell. I have really bad allergies, so it's something to consider when looking for a product, that you don't want an overwhelming smell in your hospital room. Also, they sell these little handheld things. These are great for dad or partner. Your hands might get tired. You're just constantly kneading. Or using tennis balls. I've seen a couple instructors. You put them on the base of your palm like this, and you're rubbing down mom's spine like this with the tennis balls, and then up again. And I also sometimes I put my hands like this, and I start at her lower back, and then I just slide out down the hips or across the buttocks and just kind of disperse that lower back pain. So the reason for this lower back pain is because typically the baby comes through the pelvis sideways and then turns into an anterior position where the baby's face is facing the spine. So imagine that my arm is the spine and this is your pelvis. My fingers are kind of the front of the pelvis. So the baby will come into the pelvic cavity sideways like this. And then typically, like I said, the baby turns this way. And so the face is towards the spine, and then it goes down around the crest of the pelvis, this part right here. And the baby's head will present out of the birth canal in this manner, face down, and you'll see the baby's head crowning. But sometimes what happens is that when the baby comes sideways into the pelvic cavity, they turn into a posterior position like this, and the back of their head is on the spine. And so the weight of that baby is all sitting right on the bottom of the spine, causing a lot of pain. And in this position, the baby would come down through the birth canal, what we call sunny side up. And the baby would be looking at you when they come out. But again, that head putting all the pressure on the lower spine, if you notice at the lower part of the spine on this end of the sacrum, there's a coccyx, and that has a lot of nerve endings, and it hurts really bad if the baby is just sitting on there. And so doing some of these massage techniques, the heated rice pack on your lower back, doing some of these rebozo or hip squeeze, hands and knees positions that we're going to show you in a minute, can be really relieving during back labor. So, but massage is also great for people who are having a more standard labor and feeling contractions from the spine forward or in the abdominal cavity as well. Water is another really great resource for you during labor. A lot of hospitals have a bathroom inside of your labor and delivery room that has a labor tub, or if you're at a birth center or at home, you can use one of the jacuzzi tubs. Make sure that it's a sterile environment, though, if you are doing this at home, because when your amniotic sac is open from the water breaking, any kind of bacteria that's in the bathtub can come into that cavity and introduce infection. So we want to keep that exposure down. Another reason why you don't want to use things like bath fizzers, do not use these, or the bath bombs and things like that, because you don't want that getting introduced up into the cervix. This needs to be like a sterile environment. And so another thing that you can do when you're using water therapy is having like one of those jets, or if you have like a shower head, that can be kind of like massage, but it's with water, so that hydrotherapy can be nice. And just keeping the temperature warm but not too hot because you don't want mom to overheat. You can try different positions in the tub. Leaning on the tub and kind of doing a rocking motion can be relaxing. It's also really important to drink a lot of water during labor. You want to stay hydrated and keep your energy up for what is sure to be a marathon experience, and making sure you're delivering that water to the baby as well. Relaxation exercises and meditation exercises can be really beneficial during labor. If you are anything like me, you might initially be standoffish to the whole meditation concept. However, I want to encourage you guys to be open-minded and try this together at home, because meditation can be really effective during labor in disconnecting the mind a little bit from this pain in order to focus on something else, because your brain can only think about so many things at the same time. So right now in labor, it's thinking about the pain, it's thinking about the muscles contraction and everything that goes into that process. And what happens as somebody relaxes you into a different state and starts encouraging, maybe they're walking you through your favorite hike, or you're walking along the beach and you can hear the ocean roaring, and the waves tumbling and the seagull in the distance, or maybe you hear the birds chirping or whatever is relaxing to you. Somebody is creating a mental image, and you have to use some of that mental energy that you have. It has to be pulled away from this pain in order to remember what story they're telling you or to create a new one as they describe a scenario to you. And so it's not going to completely numb this pain or completely disconnect you, but it dulls it because your body actually can't think about it completely 100%. So in our exercise, where you're going to talk about a relaxing bath, I picked the bath scenario because I think it's something the mom and partner can both relate to. And what I want you guys to do while we go through this relaxation exercise is I want you to simulate pain while we do it by using an ice cube. So we're going to have you hold an ice cube. And actually, before we start the relaxation exercise, I want you to hold this ice cube in one hand until it's so cold that you really, really, really want to let it go. And I want you to give all your focus onto how cold this ice cube is. And, it's getting really intense. And eventually your hand might go numb. And then we'll have you set it down. Okay, and then what I want to do is we're going to try it again. We're going to try it in the other hand. And when we do it in the other hand, we're going to do the relaxation exercise. And I want you to notice the difference between how intense it was when you gave it all your focus versus how you're able to dull that sensation a little bit as we focus on this relaxation exercise. Or if the relaxation exercise isn't as effective for you, try the simulated pain doing something else, maybe putting on some calm music. Or maybe your favorite music isn't calm, but that's relaxing to you. So trying this simulated pain that way. If you really don't want to use ice cubes, you could do a yoga stance. I think there's a position called the warrior where people stand like this with their arms out in this motion. And eventually what happens when you hold your arms out long enough, they start to, shake. Or if you hold some light weights, talk to your doctor. Don't go picking up 50-pound weights or something during this exercise, but just having a little bit of tension, even just holding your hands out like this, your arms will start to get tired and they'll start to be shaking, and they're very much emulating a muscular contraction. Muscles have to contract to hold your arms up like this. And being able to do this as we go through our relaxation exercises, or as somebody puts a heated rice pack on you, or as somebody gives you a massage, also starting to move, using movement, standing in place. If you stub your toe, you start jumping up and down, right? And because it hurts, and that movement distracts you from the pain. It doesn't stop the pain, but it dulls the sensation a little bit because now you're focusing on a movement and your brain can only think about so many things at the same time. So again, holding that yoga stance, holding an ice cube as we go through this relaxation exercise together, and as you practice these labor coping skills at home in order to figure out which ones work for you. And maybe the coping skill you're practicing is just your partner using some verbal encouragement, learning what types of statements they say are encouraging to you and which ones maybe annoy you, and having those discussions so that when the real deal is here, we are giving you effective and productive encouragement and using the kind of coping skills that are best for you. So I encourage you to try this relaxation exercise at home. Maybe lie down, pick some soft music that you enjoy. I usually pick something that doesn't have words. Some people like nature sounds or maybe the tumbling of the ocean. I use one called Inner Peace. You can just look them up on iTunes or something like that, Spotify. They have lots of different relaxation soundtracks where there's like 15 songs. Maybe listening to them while you go to bed and finding one that's relaxing for you. Also, I want to encourage you to maybe set the mood or try this relaxation exercise in real life. So for example, I'm going to use a warm bath, and maybe taking one and being able to really remember and exactly what we're describing, or going on a little walk and really focusing on the leaves and the ground and the wind and the breeze and all of those things that we're going to describe. So And I say that because it's easier to remember than it is to create if you're in a state of pain. So with that, let's get started. I want to encourage you to lay down, allowing yourself to sink into the comfort of your bed or the couch, maybe the bathtub. Just taking some deep breaths. As you go into the bathroom, you're going to dim the lights and you're going to start to draw a bath. The only noise will be the splashing of the water and maybe the slight flickering of a candle as you light candles along the edge of the tub. You're going to take off your bathrobe and you'll feel the softness slide down your skin slowly, across your arms, down your side, over your bum, down your legs, and eventually fall to the ground on your feet. There's a peacefulness to being naked, open, free. As you step into the water of the warm tub, you'll slide your foot in and you pay extra focused attention as the water level crosses across your leg, up your thigh, and across your abdomen as you slowly sink into the water. The water will begin to rise above your breasts as you slide down, and you feel it just at your shoulder level, slightly moving, sway to the water as you've just gotten into this relaxing tub. The only sound is the flickering of a candle and the slight movement of the water. You put your arm on the edge of the tub and you can feel the warmth of the candle, and your partner begins to rub your arm just ever so slightly. You start to feel a contraction coming on, and as your muscle begins to tighten, you slide under the water. You feel the water just barely covering your face a little bit at a time, and just feeling that water line slide over your chin, over your lips, across your nose, over your eyes, and then you feel the warm water rush through your hair as you sink beneath the water. Your hair is floating free, your scalp refreshed. Maybe you bring your hands up to your scalp and ever so lightly, slightly massage your head, focusing on the relaxation and the release of stress. You stretch your toes and release stress through both ends of your body, always away from the contraction. You continue to take deep breaths and breathe this down. You come back out of the water slowly, and again you feel the water line go across your forehead, down over your nose, across your lips, and underneath your chin as you come back up to shoulder level. The contraction is passing, and you're focused on the water droplets running down your face. Your partner continues to rub your arm, and you slowly open your eyes and look at each other. You're so in love and so excited for what's about to come. As you come out of the bath, you move slowly, allowing the water line to slowly slide down your body, feeling the water drip off of you and the warm flicker of the candle next to your leg as you step out of the bath. And your feet land on a soft, cushy rug. You grab a towel and you wrap it around your chest. You slowly slide it across and down your body, drying yourself off. Maybe you wrap another towel to wrap around your hair, trapping the warmth and the steam, keeping you warm. You rest your head against your partner's chest, and you both stand with your feet on the soft rug in the warmth of the humid room as you sway back and forth, enjoying what has been a peaceful bath. I encourage you to take some more deep breaths together, matching your partner. You're smelling in the fragrance of your candle, maybe a bath bomb. There's a lavender scent in the bathroom, maybe vanilla, peppermint. Just taking it all in. Slowly bring yourself out of this relaxation exercise, opening your eyes slowly so that your eyes can adjust to the light, and allowing yourself to smile as you look into your partner and you've passed this contraction. So this is something that you can try at home and using different scenarios and figure out one that is relaxing for you. And I hope you enjoyed it. Another form of visualization that can be beneficial during labor is picking a focal point in the room, something, maybe an object or a person or a sentimental object or picture of a family member, and something that you can focus on that pushes you to keep going, or just something that you can focus on and deter your focus away from the pain and more on an object. Also, counting through those contractions can help in just maybe counting in sequences of 10 so that it doesn't feel like it's never ending, instead of just counting however many long the seconds are, 65 to 95, where it can just feel like it's never going to stop. And it's better to count in sequences of 10. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3. And so your goal is always to get to 10. And that gives mom shorter goals and increments of time that she feels like she's accomplishing, and that's a little bit more encouraging to hang on. And also, you can use chanting or music, those kinds of things, that especially songs that might have lyrics that are helping you to visualize a different scenario. Those can be great too. I want to talk about transition. This is a phase from 7 centimeters in dilation progressing to 10 centimeters or complete dilation for mom, and at that point is when the pushing process would start. And during this transition period, mom is going to be a little bit more distressed. Those contractions are going to be very strong, very frequent. This period of time can last anywhere from a half an hour to 2 hours, give or take, and it's going to require a lot of support and encouragement. This part is tough. That I would say after about 8 centimeters or so, the pain doesn't necessarily get worse, but it's lasting longer, and your breaks are shorter, and so it can get overwhelming. And this is when mom's going to need a lot of emotional support, and you're going to maybe see some frustration from her or fear that she can't do this anymore. And this is when you really want to come in and support her and let her know, like, she is doing this. You guys are in this together. You're so proud of her. Um, and that her body is 100% capable of doing this. And, just offering those encouragement or words of encouragement and continuing to be her support person, giving her a hand if you think your hand's going to break, giving her a stress ball or something to exert that energy onto. And just reminding mom too that during this time, every single contraction, you are one step closer, one contraction closer to holding that baby and to seeing your little one that you've been waiting so long to meet. So let's move on to the pushing phase. After your 10 centimeters complete, you will be able to push. Sometimes people labor down, meaning that they're complete, but instead of pushing, they kind of wait. Sometimes medical providers recommend this with an epidural. They won't recommend laboring down for somebody who is doing an unmedicated birth. But if you are relatively pain-free in that moment, sometimes they have you labor down and not push right away in order to let the vaginal tissue stretch out a little bit so that you decrease the likelihood of tearing. For medicated or unmedicated, though, at some point while you're complete, they will ask you to start pushing. And during that process, mom is going to need a lot of support. We recommend counting through those contractions and counting through the pushes. It's really hard to push for 90 seconds long. So usually they'll have you push for about 10 seconds and then stop and then give yourself a break and then immediately go back into the push. So it'll look like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And then it'll continue to progress that way, maybe a little bit slower. I think it counted a little fast, but you can see where you're giving yourself just a second break and then recatching your breath and pushing again. And the pushing phase can take from 15 minutes to 3 hours, give or take. Most hospitals in the United States do not let you push for more than 4 hours before they will start discussing a potential cesarean. So, have that conversation with your provider and see what they think. You may or may not even need to have that. This might be a breeze for you. There is something I do want to mention with this pushing stage, which is that you do have what they call a fetal ejection reflex, and I have experienced this firsthand. So if you're not intentionally pushing, your uterus is still, the contractions are pushing this baby. So whether you are exhausted or not, because a lot of moms feel, oh, I'm so tired and I just don't have the effort, your baby is going to come out. Your body will literally eject this child out. And not that the baby's going to go flying across the room, but it is like an involuntary reflex that your body has. And I remember at one point, just crying, I can't do this anymore. And I just can't, I can't. And I remember my boyfriend telling me, yes, you can. I'm so proud of you. And they rolled me over to check me, and the baby just right out of there. So all of these contractions, this whole labor process is going to be a lot of work. And I want to do a little example. It's kind of fun for you to see what your body is going through and just why it takes so long to labor to get this baby out. So I want you to grab a balloon and a ping pong ball. You have to really stretch the edges of these. And I want you to put the ping pong ball inside of this balloon. Oops. It's a little difficult. Okay, there we go. So as you can see, this ping pong ball is going to be our baby, and the balloon is going to be the uterus. So I'll have you blow up the balloon. Okay, and then I'll have you turn it over and let that ball kind of seal the opening shut. And then what I want you to do I want mom and partner to try and work this balloon and just squeeze the balloon. And this is going to take some time, okay? And your fingers will start to get tired. And as you can see, this is starting to bulge a little bit at the bottom, but it takes a lot of contractions in order to pull this baby down. And it's moving 1 millimeter at a time. So as you're pushing and pushing, and it might take a couple hours, and you're feeling like your efforts are going nowhere, just remember that this baby is moving down through your birth canal 1 millimeter at a time, and it's going to take a really long time. And your hands might get tired. Look, just crowning. And so again, just continuing to do this until you see that ping pong ball will start to come through the birth canal. See, fetal ejection reflex. So I do this exercise because I think it's fun, but also because I want it to be clear to you what your body is going through, and so that you can have patience with this process and be excited and rest assured this baby is coming and that you are 100% capable of doing this. I want to talk about how to push. So the muscles that you're using to push this baby out are also the same muscles that you use when you were going poop, and so the sensation is going to feel very much like that there's a lot of extreme pressure on all of those organs, your intestines and the vaginal cavity. And so it's going to feel like you have to go to the bathroom. And I remember, even as the baby was coming out, it felt that way. But of course, on a more magnified scale. But how you're going to push is that they're going to, all these breathing mechanisms that we teach you and strategies, they're going to have you breathe down the baby. So focusing all the intake of oxygen, and when you breathe it out, just pushing everything with all your might down with that contraction. And you'll have these little breaks, and as the uterus contracts is when you're going to be pushing, and then when it breaks, you break. You need all that rest period you can get. Try to just close your eyes and stay quiet in that, in the intervals in between contractions. And then when contraction starts back up again, deep breath in, and then we're going to breathe down the baby. We're going to push all of our muscle strength down with the baby. Sometimes if you're having a hard time keeping up that effort, maybe you've been pushing for a long time, using like a squat bar or some kind of stress ball or something where you're able to just contract all of your muscles in this forceful push down. Because if you're just sitting there and you try to just flex your Kegel, I want you to just sit here and try to like tighten your Kegel muscles. You don't feel very powerful. Now I want you to tighten all of your muscles in your body as much as you can, and you feel like the difference there, like how much more intensity and downward energy there is with that. And I mean, you're going to try different types of positions to help you. The squatting position is probably the most beneficial ergonomically, having gravity work with you. But squat bars can kind of help you lean forward and do that too. And having something to pull against, countering that pressure. Same with if you want to do a squat, supported squats, where we have the arms crossed, holding the partner, and we're pushing that way. And you're kind of pulling on them again, that downward motion of all of your energy with each contraction. And they'll count them out. Usually you do a couple 10-second pushes where you push and you hold for 10 seconds and then you break and right back into it. You start again. Because I want to get you to push as much as you can during that contraction. And they'll probably be 60 to 90 seconds at that pushing stage. And then you'll have a short break to kind of regain your energy. Drink some water. Dads and partners, if you could just offer her the water, don't necessarily ask her, hey, do you want some water right now? Like, she might not really know. Like, if she just put it in front of her. If she wants it, she'll take it. If she doesn't, she'll push it away. Sometimes it's hard to remember to stay hydrated, just like when you're working out, sometimes you forget. So that water hydration is really important during the pushing stage. After baby is born, the first thing they will do is typically bring the baby up to your chest and put the baby skin to skin. The reason for this is because it helps regulate the baby's body temperature. It helps promote breastfeeding. It helps promote bonding. It gets your oxytocin, bringing in that milk. It also helps with the uterine involution as that oxytocin is released. So there's lots of benefits to having skin-to-skin contact, both for the baby and for you. It's not standard to weigh the baby right away. I remember being really surprised, like, well, how much does my baby weigh? And having to wait a whole nother hour to find that out. And I'm like, I've been waiting for 10 months and now I have to wait a whole nother hour now that, here she's finally here. So don't be surprised that that takes a minute. We will talk about all of the procedures that happen to your baby initially after birth in our newborn care portion of this class. But and just know that the first thing that they typically do is skin to skin contact. And they also usually try to do this even if you have a cesarean birth. Most hospitals are family centered for cesarean and they'll allow you to have one person in the room with you. And after the baby is, as long as this is not an emergency C-section, they usually try to bring the baby to you after it's been monitored and made sure the baby is stable. They'll bring it to mom and put the baby on your chest. And if mom's feeling kind of woozy or really exhausted, a partner could also try to do skin to skin contact. So keeping that in mind that it is still an option for you regardless of your birth type in most scenarios. After the delivery of your baby, you will deliver the placenta. This usually occurs about 5 to 20 minutes after the delivery of the baby. When the baby is first delivered, it's still attached to the placenta via the umbilical cord, and a partner can cut that. The medical team will instruct you on when and where to cut, and they'll provide you a pair of scissors. It's pretty thick, and it's not like cutting paper. It takes a little bit of effort, but I believe in you. And some hospitals practice delayed cord clamping, or it's something that you could look into if you're interested in doing that. That's where you have the baby out of the womb and still attach the umbilical cord for about a minute or two before they cut the cord. So there are some health benefits to that and various studies on that. So I would look into delayed cord clamping. If you are wanting to store or donate cord blood, this is something you usually have to consent to before you're in labor, because once you're in labor, you're not considered in a sound state of mind in order to give consent for things like that. So, and a lot of hospitals have you work with like a third party organization for cord blood storing. So they will collect it for you, but usually you have to bring the kit in yourself. So the medical team will collect the cord blood and then give you the kit, and you usually have to mail it back to whatever organization is storing this cord blood for you. So again, something to look into and is very hospital dependent. But anyway, so when the medical provider is delivering the placenta, sometimes they will give it a little bit of a tug to help detach it from the uterine wall. Chances are you probably won't feel this. Even in my unmedicated birth, I didn't feel the placenta being necessarily detached. I did feel it slide out of there, but it's nothing in comparison to the size of the baby that just came out of there. So rest assured, it's not too bad. You might have a little bit of contracting pain after the baby as that placenta is being delivered. You can actually have a little bit of uterine contractions that continue on after the baby has been delivered as the uterus is involuting back to its normal size. I did not notice this as a first-time mom, but after my second baby, I noticed it significantly stronger, specifically when breastfeeding or pumping, because that oxytocin, it causes uterine contractions to help with that involution, another pro to breastfeeding. And so sometimes you will notice some uterine contractions even in days after the baby is born, and potentially longer. So don't be surprised if that happens. If it's extremely bad pain, definitely call your medical provider. But some relatively moderate or less severe uterine contractions is normal. If the placenta has anything abnormal about it or any kind of large lumps or something like that, or if there was ever a suspected placental abruption during labor, you might hear the medical staff mention that they're going to send the placenta to pathology. So if you had plans to store or encapsulate your placenta, definitely make sure that that's part of your birth plan and that your medical team is aware, and it may or may not be an option in the case that they need to send the placental to pathology. So just double check on that if it was something you were interested in. We're going to move on to discussing some different positions that are available to you during labor. I have a friend with me who is going to help us demonstrate these positions, and I encourage you guys to practice these at home with a partner. There are a lot of reasons that we have you change positions during labor. Some of them is maybe the baby is malpositioned and they want to turn the baby from a transverse or sideways position into a head down position, or maybe the baby's breech, meaning the feet are down, and they want to completely flip this baby so that it's head down. That usually requires manual turning as well, and so the medical staff might be pushing on the baby to try to get the baby to spin. But there are some position changes too that promote the baby flipping or spinning into a different position. And there's a great website out there called Spinning Babies that has all kinds of tips on that. Also, if the baby is in a posterior position and they want it to turn into an anterior position, just a variety of reasons that they would want you moving around. Also, having gravity work with you as you're up and walking around, getting that baby to descend into the birth canal as the uterus is contracting down on the baby. Also, even if you get epidural and you're not choosing to do the unmedicated route, they're still going to want you to do some position changes. If you are laying on the bed, epidurals are gravity dependent, and it will sink to one side. So they're going to constantly have you rotating from one side to the other side. They might have you using peanut balls and propping your legs up, depending on the level of your epidural. Or the strength of your epidural, they might be able to turn you around into a modified hands and knees position, leaning against the bed. All of those things are going to help with this progression of labor down into the birth canal so that you can meet your baby. And I want that transition to be as smooth as it can, and I want you to have lots of options so that you're comfortable. So hang in there, this is going to be fun, and let's get to it. So one of the positions you could do would be while standing. You could rock with your partner, kind of do a chest lean like this. And as the contraction comes on, you can rock with mom. She might end up pulling down into a squat and holding you from this position. You could even put your chest to chest and wrap your arms around for some extra support. This position is really great for getting your oxytocin flowing. You're right there with the person that you love. Oh, we're really close because my hair is stuck to her hair. Oh, geez. So a great position for birthing and for laboring through contractions that's ergonomic for your body would be to do some squatting positions. I really like squatting with a birth ball. I think that the rocking helps me get through the painfulness of the contraction, just like when you stub your toe, you kind of move around and you're hopping around. I like being able to rock through that squatting position. So I can put my head on the birth ball, I can put my chest on the birth ball, as long as I'm in this squatted position. And this really helps promote the baby to drop down through the pelvis because it opens your pelvis up to 20%. Another great squatting position would be to do an assisted squat. There's a couple different forms of this. One of them, if you have one or two birth partners, you would all squat together. So we've got maybe mom and dad or whoever your birth partner is, and you can put your arms around each person's shoulders. You could also, if you just have one birth partner, you can put both arms around their shoulders. You could put your head and weight onto their knee and squat through that contraction. There's another type of assisted squat. We try not to do a squat where you're holding their hands, because when you drop, it pulls them down. Not that you would go that fast, but it pulls their weight forward and they have a hard time holding this position for long periods of time. It starts to pull on your back. If you do a crisscrossed arm supported squat, when you drop down, it allows them to kind of counterbalance your pull. So when I'm pulling through the contraction,
the birth partner is also pulling the opposite direction to counterbalance my weight. And then as I come out of that contraction, I can use their arms as leverage to pull myself back up. And we always want to help mom and support her as she gets back up. We don't want pregnant people tipping over. Sometimes your bed will have a squat bar, and that hangs on the end of the hospital bed, and you can hold that and do a squatting position at the end of your bed, and that really helps, being able to pull some of that muscle tension into your arms, and you're kind of squeezing through this contraction, and that's a great squatting position as well. So in another sitting position, when mom's in a chair or on preferably a hard surface, if you have the birth partner push on mom's knees, notice what happens to Brandy's lower back. It moves and tilts the pelvic cavity forward, and this is a better position for a baby to come down in. It also alleviates some of that pressure off the lower back. So sometimes just having mom sit on a chair through the contraction and having dad contractions coming on, pushing on her knees, and she can kind of counter that pressure a little bit. Another hands and knees type position would be an asymmetrical kneel. So you're on one knee and you have one leg up. You're opening the pelvic cavity, having gravity work with you as you push. I kind of like to hold my shin here and pull against it as I'm countering the pressure of the contraction. So that's a great position as well. So some of the positions that we promote during labor would be for sitting positions. I really like using a birth ball. I think it allows you to open up your hips. It allows you to move around and keep some of that mobility. It allows the baby to turn a little bit if that's a position that you're going for. You could use another partner and kind of lean into them, just like we did in that squatting position, and pull on them through that contraction. Also, you could do a sitting position in your bed, especially if you had an epidural. When it comes time to push, if you're leaned against your bed like this, they have positions where both of your heads, very Hollywood-esque, both of your legs are up like this, and they'll have the mom hold her legs and pull through that contraction as she pushes the baby downward. Sometimes they have you use one leg, and you're pulling on one leg and trying to keep this area open. This is really great if you have hip pain during labor. We also have a squat bar, and we'll pretend that Brandy's hands are a squat bar, and you kind of pull yourself up, but you're still in this sitting position. These are all really great positions for trying during labor. Sometimes people have what we call back labor, and that's where the baby's head is or face is sitting on the end of your spine, and it can cause painful contractions in the back. And so in order to alleviate that pressure, sometimes the medical staff will recommend that you try a hands and knees position. There are a couple of different hands and knees positions that I like. I really like using a birthing ball. So when I'm on my knees, I can lean forward like this and kind of rock with the contraction. I also like doing hip squeezes and trying to push the pelvis together and alleviate some of that back pain. So I'll show that with Brandy. So once mom is on her hands and knees, you're going to trace her body until you find the top of her hips. And then once you find that top of the bone, you'll pull your hands in until the corners of your hands touch. And that's the point that you want to move your hands out and slide down the side and push up and squeeze together. And this is supposed to move the pelvis a little bit and alleviate some of that pressure off of the lower spine during the contraction. Now, birth partners, this is really exhausting. You can do this, but it gets tiring, so we have an alternative type of hip squeeze that we suggest using a rebozo for. So if Brandy stand up, you can do this on yourself or with a birth partner. So we have here, I'll have you turn sideways. We wrap the rebozo kind of around mom's bum, which will sit right on her hip bone there. And as you can see here. And a rebozo is just a type of Mexican scarf that Mexican midwives used to use. And what we do is, like I said, we're wrapping it from the hip bone to just underneath the bum. And then mom can squeeze or the partner can squeeze. So the contraction's coming on and you squeeze them together, and this should bring the the pelvic bones together and alleviate some of that pressure. Mom can do it herself too. So she feels the contraction coming on. This is also great for cultures who don't necessarily feel comfortable with pelvic touch. So this is a great alternative to that as well. And a lot of moms find comfort doing this. It also is really comfortable when you're pregnant. In those last couple weeks, there's a lot of hip tension. Another great rebozo technique would be if mom's on her hands and knees. We'll take the scarf and we're going to bring it underneath mom's belly. We'll bring up one side first, and then we'll bring the other side of the scarf up. And the idea is to wrap the scarf around mom's belly, and then when the contraction comes on, pulling up, of course gently, in order to alleviate that weight of the baby in the hands and knees position, pulling it off of mom, and you're just holding the weight of the baby through the contraction as mom labors. And then as she comes out of the contraction, you would slowly let down. Don't just drop the baby. We always talk about dropping the baby afterwards. Let's not drop it during labor either, okay? If you have an epidural, most likely you will be using a side labor position. So one of the lying positions would be if you're on your side. They will use either a peanut ball or a birthing ball, and they'll prop your legs like this. And the reason you're going to be on your side is because when they place the epidural is gravity dependent. And so it will start to settle on one half of your body, and people will claim, oh, this side is more numb than the other side. So they're constantly rotating you from side to side. So there's a good chance, if you can't feel anything from the waist down, that you're going to be restricted to a lying position. Sometimes epidurals are lighter and you can use some of those hands and knees positions, but for the most part, I've seen people in lying positions. So side by side is really common. They give you a peanut ball or maybe a pillow or a birthing ball, and this keeps the pelvic cavity open. They'll also recommend a lying on your side position if labor is really fast. So they do this sometimes to slow labor down a little bit so that mom's able to tolerate the transition a little bit better. So this is a really great position. Another lying position. They won't ever have you lying on your back for a long period of time. But if you have an epidural and it's time to push, they're going to bring the bed up into a semi-sitting position, in which case we would try some of those laboring positions we talked about earlier, where you have both legs up like this, the one leg, or a squat bar. And those are some positions that you'll use as well. But you're never going to be lying completely on your back during labor. And that is because it puts pressure on the vena cava, and we don't want to block blood supply to the baby or to you and make you lightheaded during what's already a really stressful process or can be. So that is the reason for that.
So I want to talk about some different pain management options that are available to you in the hospital. We'll start with nitrous. So nitrous is a medication that is self-administered during labor, and it is like half N2O and half oxygen. And some of the pros to this type of pain management is that it only affects the mom's respiratory system. So this is a type of pain management that's only affecting mom, and it's not being passed through the placenta to the baby. However, a con to that is that it doesn't offer necessarily full pain relief. More, it just takes the edge off. And so another con to that can be that some people report that they feel dizzy or disoriented, or they just don't like it, in which case it is temporary. It only lasts for a short period of time, a couple seconds to a couple minutes, depending on how long that you're administering it to yourself. And so if you don't like it, you can just stop it. So it is temporary, which can be a good or a bad thing. You do have to time that. It's not going to be like an epidural that is constant pain relief that you don't really have to think about. It is something that you have to start to give it to yourself because it takes a couple seconds to kick in as you feel the contraction coming on. So there's a little bit of learning that you'll have to do if you choose to do nitrous oxide. It's also not something that every hospital offers, so you'll want to call around, and if that's something that you're interested in, do some research and make sure it's something that your facility is going to offer. Another form of pain management that's available to you at the hospital are analgesics. So those are narcotics that they can give you during labor. They usually try to give these to you at least, about 2 hours before they think that the baby would be born. And the reason for that is because unlike nitrous, that's only working on the respiratory system, analgesics are systemic. So they affect your entire body, and they kind of alter your perception of pain as well. And so these can be passed to the baby. So a con there is that, um, in the case that you were to deliver the baby before that 2 hour time frame, instead of the adult liver processing that medication, the baby's liver is processing that medication. And so it it does get passed to the baby. Sometimes we see these babies are a little bit more drowsy. It does eventually wear off, but something to consider there. And it can affect your blood pressure. Sometimes people have reactions to those types of narcotics. They can make you feel kind of nauseous. These can make you a little bit foggy. A lot of people report that, and they don't offer complete pain relief. It's more of a dulled sensation or a dulled perception of pain. But the pro to this is that it usually wears off before the pushing phase, and you can try to be as present as you can. You're still able to get up and move and do these different positions that help allow gravity to act on the baby versus an epidural where you have to be laid down. So that's the main pro there, is that you still would be able to maintain all of that movement for the most part. They don't usually let you walk the halls because those types of pain medications can make you, again, a little bit foggy. And so they'll want you to keep that movement within your room. The final form of pain relief that is available to you, the hospital, most people are very familiar with epidurals. So about 85%, maybe even more, of births in the United States are with an epidural. So the reason that epidurals are so popular is because they provide the most effective pain relief. So most of the time you get complete pain relief, and to the point that moms are able to nap while, at 10 centimeters dilated. And you will still feel some pressure and those kinds of things, but you're not in any kind of immense pain. And epidurals are a regional anesthetic, meaning that they only affect a certain portion of the body. So unlike analgesics that affect your whole body and can oftentimes give you like head side effects where you feel a little out of it, epidurals are just regional, and so it's only applying to this region down, and you're not feeling high, you're mentally present, and so it's very popular for those reasons. However, there are cons to having an epidural. So depending on what stage of your labor you're in, an epidural can slow your labor down, which then also increases your risk for needing augmentation or Pitocin. And there is another risk with epidurals, that you can have your blood pressure lower, which then can cause the baby's heart rate to drop. And so you'll need constant fetal monitoring if you get an epidural and a blood pressure cuff. And also they will be making sure that you're on IV fluids to try to regulate your blood pressure. So the second that you get an epidural, a lot of other medical interventions come with it. And so those are just, some basic cons with that. There's also some potential that you could get a fever, and once you get a fever from the epidural, it's hard to know, is it from the epidural or is it because mom has an infection? So sometimes you'll have to get an antibiotic preemptively just in case you do have an infection, even if it is just caused from the epidural. You could also have, it's very uncommon, but sometimes you could have your cerebrospinal fluid leak a little bit if there was a puncture at all. You could get what they call a spinal headache. There could be some itching or local pain at the site of where the needle goes in. And then, of course, there are some very serious side effects that are very, very rare, like paralysis or death, but those types of um, side effects are extremely rare in epidurals. Like we said, 85% of people are getting them, and the majority of all of those people survive. And most people report that they appreciate and are happy with their epidural. So I don't say those things to discourage you from getting one, but just to be aware that there are potential side effects. Another side effect of epidurals is that they do affect your pushing ability. Once you are numb from the waist down, sometimes women have a harder time feeling those contractions and feeling the urge to push. And so sometimes we see more tearing with patients who have epidurals because of their inability to feel those urges to push, and they have guided or coached pushing, which can just affect the amount of pressure that you're putting on your vaginal opening. And also, just the positions that you can use with an epidural are limited, so that can affect tearing as well because you're not working necessarily with gravity. There are some new modified positions for people who are using epidurals who want a little bit more gravitational pull with the birth, but typically with an epidural, you are stuck in one position, at least on the bed. If your epidural, they're able to gauge them a little bit now, and so they can kind of lighten them so that you can feel more. And if you have a light enough epidural, you can try some different positions. Sometimes they can do like a modified hands and knees, or have you lift up into a squat bar. I know when I had one of my epidurals, the like my legs didn't move at all, so that wasn't an option for me. But I've had multiple friends and my sister who were able to like move their legs and change position. So I think it just depends on the degree of your epidural. Some of the epidurals too have like a button, so they can start at low, and if you're starting to feel like your contractions are getting stronger, you can just add a little bit, and they make it safe so that you can't overdose yourself with the epidural. But um, that's kind of an option for you there too. Another con, aside from the limitation of positions, is that you won't be able to eat if you get an epidural during labor. So make sure that you eat whatever you want before that, because you won't be able to get up and go to the bathroom. So they don't want that happening either. So they'll give you a catheter for that. And then the other reason you won't be able to eat is because of the anesthesia risk. So with an epidural, you could end up, it does increase your risk of getting a cesarean. And in the case that you need a cesarean, they don't want you to have had any food in your stomach for the risk that you could throw up and aspirate it while in surgery. So if you do choose to get an epidural, you'll be confined to clear liquids during that process, and then you'll be able to return to eating food after you have the baby. If you do an unmedicated birth, this does not apply, and you are welcome to eat during labor. However, I don't know if you'll really be up for it. So there are lots of pros and cons with all of these different types of medical interventions, and we just really want you to focus on learning and practicing informed decision making. Some types of medical intervention that you might see during labor are the standard would be to get an IV. And the reason that they promote getting an IV is that regardless of whether your plan is to do a medicated or unmedicated birth, sometimes things go wrong. And in the case that you needed some sort of unplanned or emergency C-section, an IV allows it. It just takes out a step, so it allows you to make that transition quicker. And instead of trying to fiddle with an IV, they can just get you the medication for the anesthesia intravenously and transport you to the operating room. And it just allows you to get medication quicker. It allows you to get IV fluids quicker. And of course, in the case of an emergency, it just makes the whole process a little bit faster. And it might not seem important to you in the beginning, but in a situation like that, it could very well be. Time is everything. So they have like saline or heparin blocks, and so they'll start the IV. There just won't be anything hooked up to it. There are pros and cons to getting an IV as well. So it might sound really great. There are cons, Anytime that you're puncturing your skin, you could introduce infection. A lot of people find that they bruise and they can cause discomfort, or that they could snag on something. If you do get an IV that's hooked up to fluids, some people are concerned that it limits your mobility a little bit because you're attached to a pole with a bag of fluids or medication. Um, that's not always true. Usually you can disconnect the IV temporarily to try some different position changes or walk around. Um, Also, they can be itchy if you had any kind of reaction to the adhesive or the injection site or something like that. So again, every kind of medical intervention is going to have a pro and a con. Another type of medical intervention that's pretty basic and standard is fetal monitoring. If you choose to do an unmedicated birth, they still usually recommend that you monitor for like 20 minutes out of the hour. So 20 minutes on, 40 minutes off, and 20 minutes on, 40 minutes off. And they just want to check in, see how baby's doing, watch the heart rate, and see how baby is coping with labor, and see if there's certain positions that are better for the baby, that kind of thing. And they also might manually feel to see what kind of position the baby's in. Most of the time, you should have already had an ultrasound that determines whether a baby is head down or not. But there's fetal monitoring for those different reasons. And most fetal monitoring during labor is external. So they have these like two monitors. They usually put one up here and one down here, and they use one of these strappy things on your belly to hold them on there. So they're stretchy, and they're always fidgeting with them because they slide around and they're trying to track baby's heart, and those little guys like to move around. The other form, if they're really having a hard time getting the reading, maybe baby's moving a lot or something like that, they can do an internal monitor. So it's like a really long string, and it has like a little coat on the head, and they stick it through the vaginal cavity, and then they place it right on the baby's head, and so they can read the baby's heart rate that way. So internal versus external monitoring. Depending on the hospital you go to, getting fetal monitoring may limit your mobility, but some of them have the ones that detach and you're not attached to a cord. They also have some that are waterproof. So if you wanted to do like a water birth or labor in the tub, some of those fetal monitors can come with you. Again, you'll just have to check the facility that you are planning to deliver at and see if that's an option for you. Another type of medical intervention that you might come across is the blood pressure cuff. And the blood pressure cuff is just to make sure and see how you're coping with labor as well. And also, you could be given a antibiotic during labor when you first get to the hospital if you ever tested positive for group B strep. So group B strep is a bacteria that you always have in your body, but sometimes it's higher than normal and sometimes it's less. I think with my first child, my group B strep was negative, and the second time it was positive. And so they typically want to give you antibiotics, I think it's at least 4 hours before the baby is born, so that it's in your system and passed through to the baby to prevent the baby from contracting this bacteria. But in my case, I had a pretty precipitous delivery, and so they did give me the antibiotic, but it wasn't 4 hours before the baby was born. So in that scenario, then after the baby is born, they would give the baby the antibiotic as well. So that's another type of medical intervention that you might see, or antibiotics used in labor for either fevers or for group B strep. And the con would be that some people don't believe in antibiotics, or some people might be allergic to the antibiotic, and so they have to find a different one that works for them. Or maybe they don't want to take any medications, and that's always a scenario as well. I want to point out that during labor, the medical team will do a series of cervical checks periodically, and what they're looking for is to check for your effacement and dilation. So they're manually going to stick a gloved hand up into the vaginal cavity, and they're feeling for the top of the baby's head, and then they're able to spread their fingers and feel when they hit this corner of your pelvis, this ischial spine, and that's how they know how wide or how dilated your cervix is. And they're also feeling to see how effaced you are, or how thinned out that cervix is. And sometimes you'll also hear them talk about, oh, she's -1 or she's +1. And what they're referring to is your station, and meaning the station of the baby. And if the baby is higher in the pelvic cavity, they say, oh, she's -2. If the baby has dropped lower than this ischial spine, oh, she's +1. And those numbers are referring to centimeters. That's how far the baby has progressed through the pelvic cavity. And a lot of moms want them to check regularly. Oh, how far along am I? Especially if you're in a lot of pain, you're wondering, how close am I? And the reason they're not going to check you super frequently is because they don't want to introduce any kind of bacteria. Anytime they insert anything into the vaginal cavity during birth, there's a risk for infection. So they're going to minimize the amount of checks that they're doing. If you do feel any kind of severe change in pain or a lot of rectal pressure, you can request that they please do a check, because that can mean that things are progressing like much quicker or right now. So just keep in contact with your nurse and see what your hospital's policy is on the frequency of cervical checks. There are a variety of induction methods, both natural and hospital induction methods that require medical intervention. Things that you can try at home include things that get oxytocin flowing, cuddling, going on a date, making out, sex. Sex actually helps for multiple different reasons. So sperm is a prostaglandin that acts as a cervical ripening agent and kind of eats away at that cervix and helps to promote labor in that way. It also, sex can cause you to have an orgasm. Well, good sex can cause you to have an orgasm, but it's kind of hard to have good sex when you're 41 weeks pregnant. So there's that. But the orgasm is actually a uterine contraction as well. And so that those uterine contractions can kind of push your body into going into true labor. So it can be beneficial in that way as well. And then also, there are lots of different things people recommend that you eat, like spicy food, or I've heard dates. I haven't personally tried that, so I'm not sure. Something that is another prostaglandin actually is red raspberry tea, and I've heard primrose oil is pretty effective as well. Red raspberry tea and primrose oil, I recommend that you speak with a provider before taking those types of supplements, because they are also prostaglandins, and making sure that you are ready to be inducing yourself into labor before trying things like that. Something I recommend you do not try at home is using castor oil in order to induce labor. So the reason that castor oil can work is because it's not meant to be ingested, and it causes diarrhea. And diarrhea can cause you to go into labor because of the muscular contractions in your abdomen from the diarrhea. And the main reason that, well, probably two reasons that I recommend you do not try this at home is that it doesn't always work. And then you're just 40 something weeks pregnant and you have terrible diarrhea, and nobody wants to do that. And the second reason is because most people don't want to be having diarrhea while in labor or while giving birth. So it's not really worth the risk. There are lots of other methods that are just as effective. Also, walking around, walking and doing squats, getting that pelvic cavity ready, having gravity, pull on the baby. I know that days before and while in labor, I walked around, and that kind of got things moving at least a little bit quicker. So it's more, it can be an induction method, but mostly walking around once you're already in labor, so an augmentation method. And augmentation means that we're speeding labor along. So we'll get to that in a second. I want to talk about inductions using medical intervention. So I don't think anybody just signs up and is like, yep, I would love all of the medical intervention that I can get, and please give me Pitocin. However, sometimes Pitocin is the only thing that's left that can help you have that natural vaginal birth that you're wanting. And so it can be a great resource for you, and it can also be a life-saving type of drug if you're in a position where you're either already in labor and needing it to be augmented, or you're significantly past your due date and they're concerned that the baby could get stuck or experience some sort of medical issue, or if you're not quite to term yet, but maybe you have severe preeclampsia and staying pregnant is more of a threat to your life and the baby's life than delivering the baby. And so there are lots of different scenarios on why we would use Pitocin to either induce or augment labor. So if your care provider is recommending that, stay a little bit open-minded. Still advocate for yourself if it's not, you're welcome to say, not yet, or what are my other options? And opening that dialogue and having a conversation with your healthcare provider. And this is why it's so important that you pick a good obstetrician or midwife to help you through this process that understands your desires and preferences for your birth experience. Pitocin is the synthetic form of oxytocin. So, oxytocin again is that hormone that's released when we feel loved and when we feel safe that causes uterine contractions, which thus promotes labor and initiates labor. So, Pitocin emulates oxytocin, and a lot of times it will even say oxytocin on the bag of medication that is coming into your IV. And you'll hear the medical term or medical staff use the term PIT, and they'll say, "Oh, she just started on PIT," and they're referring to Pitocin. So some of the pros of Pitocin, like we talked about, is that it can help initiate and it can help augment labor, so getting things moving along quicker so that the delivery goes smoother, or that baby is delivered healthier, or the mom is healthier. So for whatever medical reason that they feel you needed, that is the pro. The cons to Pitocin is that it can cause very strong contractions. And so a lot of women will report that their contractions while on Pitocin felt more painful than without. And also it can cause you to have a little bit longer of a labor because it is an induction method. You're not spontaneously going to labor, so it can take a little bit of time for your body to respond to that Pitocin and start going into labor. And so it's longer and it can be stronger contractions. So with that, usually Pitocin and epidurals go hand in hand. A lot of people get end up getting an epidural due to the sheer length of a longer labor, being more exhausted and the pain of that being stronger, that they end up getting an epidural, and vice versa. A lot of people who maybe didn't start out on Pitocin, but they got an epidural, and epidurals can slow down your labor. And so then a lot of times after an epidural, somebody would recommend that you take Pitocin in order to speed your labor back up. And that depends on what stage of your labor you get that epidural in, or sorry, which phase of labor you get your epidural in. So those kind of go hand in hand, and some people might view that as a potential con, that there's an increased risk of wanting an epidural. And then also, when you get Pitocin, that is typically an IV med from what I've ever seen, and so you will need an IV if you require Pitocin. Some interventions that you might have happen in a medical setting if inducing a labor would be stripping the membranes. This is where the doctor goes in and manually will try to separate the thin membranes along the amniotic sac and the uterus. Also, you might get like a cervical ripening agent. This sometimes this is an oral medication, and sometimes it is something that they manually put into the vagina, and they'll have you lay down so that it all dissolves and that can act on the cervix and help to, quote, ripen it, or help efface it a little bit in order to induce labor. And then also sometimes they do, like, if you're already in labor but maybe you're not dilating quite the way that they want to make that happen a little faster, sometimes they use Foley bulbs that help dilate a little bit for you. They can kind of blow up the balloon and kind of try to initiate that positive feedback mechanism and get the body to start doing it on its own as it's being triggered by something else. And then also, this is different than a Foley catheter. Foley catheters are usually placed after epidurals, or if they're worried about having your bladder being able to be released, because if you have an epidural, you won't be able to get up and go to the bathroom. And so they'll place a Foley catheter in that scenario. Another form of medical intervention that you might see in labor is an episiotomy. Again, that is when we make a slight slice in the perineal tissue. So you have your urethra, and then your vagina, and then your anus, and the tissue in between your vaginal opening and your anus is called the perineum. And sometimes that we see that tear when the baby is coming out if there's not quite enough room for them. And so they can sometimes make a little slice there just so that that opening is a little bit wider in order to prevent a severe tear. Because if the hole is too small and baby's coming through and it tears all the way, they're trying to prevent a full vaginal to rectal tear if they do an episiotomy. They're very uncommon, like we said. They don't really do them anymore due to risk of infection, and they're harder to heal than a natural tear. But it is something that does have pros and cons as well, and something that you will have to discuss with your healthcare provider. The use of vacuum and forceps is another medical intervention that you might see during the posting stage of labor. A lot of people have negative stigma and fears over the vacuum and forceps, and I just want to shed a little bit of light on why they use these tools during labor sometimes. So vacuums are, it's not an intense suction, but the idea is to aid mom in her pushing. So baby is doing great, but mom is tired, and maybe the uterus is not pushing as strongly. And so the idea is to help mom as she pushes, suction the baby to make that delivery go a little bit smoother and quicker so that baby doesn't become stressed in the birth canal. Forceps are usually used when the baby is stressed out, but mom is doing great. So mom's pushing it with lots of effort and she's doing well, but the baby is stressed out and maybe they need to reposition the baby, and so they can use a vacuum and forceps if necessary. The cons to using a vacuum is that, it could cause a little bit of a cone head and maybe some light bruising. Same for forceps, they could cause some light bruising or maybe a little bit of nerve damage in the cheeks. But usually, if you're in that scenario, the pro of them may outweigh the con. That would be for you to decide. And the one of the bigger pros is that most women who are in that scenario where they're pushing, their goal is to have a vaginal delivery, whether it be medicated or unmedicated. They're wanting a vaginal delivery, and using a vacuum or forceps could be that last effort that prevents you from going to a cesarean. And not that there's anything wrong with a cesarean birth, but if you're already that far and the baby is in the birth canal, going to a cesarean is kind of reversed. So that means the baby is stuck and they're going to have to try to re-pull it back out of the birth canal. And so this could be the last effort that prevents you from going to a cesarean, which is abdominal surgery, and something that you may want to avoid. So there are pros and cons to all of these different interventions. So I've had a lot of people ask me, with all of these medical interventions, forceps and vacuums and those kinds of things that happen during birth, why not just go to a cesarean? And the reason for that is because although cesareans are a life-saving procedure, they are a lot on the mom. It's a longer recovery period, but also the contracting on the baby during a vaginal birth all those contractions are helping to squeeze that amniotic fluid out of the baby's lungs. And that's a really important part of the birth process. And of course, if you are in a cesarean section, they're going to take the baby away immediately and suck that fluid out manually. But we like to let the body try to do what it was designed to do first. And it's typically the best for you and your baby to try that natural means of a vaginal birth first.
Now, there are lots of scenarios where a cesarean is the safer option. So that's why we discuss that as well.
There is a lot of negative stigma in our society right now around cesarean births because our cesareans are at an all-time high for the most part. About a third of births end up in a cesarean, if not a little bit higher. And I want to talk about this mostly because I feel like a lot of women think that if you have a cesarean, that it's not a true birth, and that it's not natural, and that somehow a natural birth is better. And I think a live baby is the best case scenario in any birth, and sometimes a cesarean is the only option to have a mom and a healthy mom and a healthy baby as the outcome of a birth. And so anytime that you're making a sacrifice for something that you want, or a sacrifice of your body in order to provide or keep your baby alive, I think that's something to celebrate, and it's something to be proud of, regardless of whether or not it was the initial outcome that you wanted. Um, but let's talk a bit about what that process actually looks like. So if you do end up in a cesarean birth, um, or maybe you elect to have a cesarean birth or your hospital doesn't allow a VBAC option, meaning a vaginal birth after cesarean. Um, if you are doing a cesarean, they will bring you into a room and usually prep you. You'll wear a hospital gown initially when they pull you in there. And then once you get into the operating room, they'll have you remove your gown, or at least pull it up onto your chest, and they will hang a drape. And then sometimes they will shave a little bit of the top of your pubic hair away from your belly line so that they have a nice clean surface, a clean sterile surface, and they'll wash it off with a bunch of different like iodine and other sterile products. And then they will make an incision through your abdominal, or well, actually, the first layer they cut through is your skin and that fatty tissue. And then they will open up the abdominal muscle wall, making a separate incision. And so they're doing this layer by layer. And then underneath your abdominal muscles is where your uterus lies when you're pregnant. And so they make a small incision at the base of your uterus, and they will then pull the baby out through the uterus, and your baby will be born that way. And most hospitals practice like a family-centered cesarean birth, where the baby is then brought, the cord is cut by the surgeon, and then the baby is brought around to the mom and partner, and they're either able to do skin to skin. Sometimes they take the baby to the warmer first because the operating rooms are very cold, and stabilize baby, or get some vitals. But then oftentimes they bring the baby back to mom and put the baby skin to skin. If for some reason you're in a cesarean because there's something wrong with the baby, and maybe the baby's having a medical condition, and they take the baby to the NICU, after mom's surgery is complete, they will clean out the uterus and do their best to get most of the blood out. They finish stitching it up, and they use sutures that will dissolve, and they sew each layer back up very precisely. And then after mom is healed for a little bit and stabilized, then she can follow the baby to the NICU. So oftentimes, if the baby does go to the NICU, the partner or husband is welcome to go with the baby. I think a lot of times they encourage that so that the dad can make medical decisions for the baby in the NICU, but you're also welcome to stay with mom. So that is an option as well. So cesareans are relatively safe for being an abdominal surgery, but it is a lot of care. You're going to be expected to recover from abdominal surgery while taking care of a newborn, as if that's not already an exhausting process. So, be patient with yourself. You are going to be sore. You will still bleed after you have the cesarean vaginally in order to get all of that out. So you will still have that, have to wear pads and all of that, even if you have a cesarean birth. And the recovery period is actually a little bit longer than with a vaginal birth. Your recovery period is about 8 weeks postpartum. So there are some changes there. And of course, your doctors will teach you how to take care of that wound site and all of that. And you'll have to be kind of careful how you position baby while breastfeeding to avoid contacting or putting too much pressure on your abdominal cavity. When we talk about cesareans, I think that it's important to point out there are different types of cesarean sections. There are planned cesareans. These happen usually if you are having maybe multiples or there's some kind of medical reason that you would need a C-section. If you've had a prior C-section, that can be a reason that they suggest doing it again due to scar tissue. But VBACs, meaning vaginal birth after cesarean, are becoming a more frequent and common thing. So just check with your hospital and whether that's something that they allow at their hospital. Also, there are unplanned pregnancies. There are unplanned cesareans, and this just means that your intention was you came in with a vaginal, the intent to deliver vaginally, but then maybe mom is doing great, but baby's heart rate is all over the place, or maybe baby's not doing that great, but or mom is not doing great, but baby's doing great, or something like that. And so for whatever medical reason, they think that a cesarean has now become a safer option than a vaginal birth. So that would be an unplanned cesarean. And then there are emergency C-sections. And a lot of times I'll hear people say, oh, I had an emergency C-section. Emergency C-sections are actually extremely uncommon. They're less than like 1% of all births. And they require general anesthesia. So the mom is actually put under complete anesthesia and would not be awake and alert during the procedure. And these usually happen in like very intense medical situations where they're either the mom or baby's life is being considered, and that this is like life or death, and there are like a couple minutes to get this baby out. And the procedures for that are a little bit different. But again, this is a very low probability, and most people actually had an unplanned cesarean. So I encourage all of you to take this information and apply it, practice it at home. Also come up with a birth plan, a list of some of your preferences, maybe any kind of cultural values or beliefs that you have behind why you want your birth to move forward in a particular way, or why you don't want it to move forward in a particular way. So those things are really helpful for the medical team, and it helps us to stay as close to your birth plan as possible. And if for some reason something needs to change in order to provide the best care for you or your baby, we're able to kind of negotiate and come up with a comfortable alternative for everybody. And so again, I just encourage you to bring that, think about it, talk about it with your partner, and figure out what looks like the optimal birth experience for you. And remember to be flexible because every birth is different and there's a wide range of normal in this category. A lot of moms ask me about tearing, and is it normal or is it super common? The most common type of tear is a second-degree tear, so a little bit into the perineum. We also see some slight vaginal tears, and they'll stitch those back up, usually with dissolvable stitches. In order to prevent tearing, there are a couple things that you can do. A lot of times people do perineal massages both before they're in labor and during labor. A lot of times the medical staff will be kind of stretching on that tissue as you're pushing. And again, sometimes they'll have you laboring down and just letting the baby kind of rest on that and slowly descend through the birth canal. So those kinds of things can help there. If you do tear, after you have a baby, they will give you some products to help take care of that, and I'll show you those in a second. And one of them is a numbing spray. This is the one that they gave me at the hospital, and they have you spray this on that wound after it's all healed up before you go to the bathroom, so that your urine doesn't sting it so much. Or if you're going to go have your first bowel movement, they'll give you a stool softener so that you're not having to put a ton of pressure down there in order to pass some stool. And so that kind of helps alleviate some of the pressure too. They also give you some of these medicated pad wipes and a little water bottle. So this will just be like warm water or cold water if that's more relieving to you. And so you can do either or both. So the numbing spray and rinsing that area afterwards with water, especially rinsing, a nice tip is using this water as you're peeing, and it's diluting that so that it's not so strong and acidic where it stings. So kind of literally just as you're peeing, squirting this on the same area, and that can be really helpful too. You're also probably going to get quite a few of these little numbers, these granny panties. These are probably the most comfortable underwear you will ever own. Unfortunately, it's not socially acceptable to wear them regularly, or else I would. Um, so they're pretty stretchy and they don't put any kind of pressure on your tummy. So these are great for people who have had vaginal births or cesarean births. And they are pretty wide. And so they allow for these larger pads that they're going to give you. I'll show you some of those. So this is usually the standard one they give you. It's pretty large. You're going to have padding on the bed too for extra bleeding, but this will be probably the size of the first pad that they give you. And this one has an ice pack on top of it. I actually have a little tip for ice packs. If you have a diaper, you can pull the diaper apart just like this, like you would from a chip bag, and then pull it apart from the side that has the little sticky clasps on it. So pull it apart like a bag of chips, put some ice cubes down into it, and it's kind of good, this like cottony stuff is inside of there, and then roll the end and use those stickers on the ends to seal it back up. And now you have this perfect ice pack. And the nice thing about these ice packs is that you can put them in your underwear and it feels cool, but as they melt, instead of getting condensation all over your bed or your underwear like a true ice pack would, as the ice melts, it just absorbs right into the diaper. And you're probably going to have a lot of diapers on hand, so you can store lots of them in the freezer. So don't rush out and try to buy a bunch of those frozen jelly ones. Also, they can be kind of hard-sided, and the diapers are not nice and soft, especially if you do have any kind of tearing. Um, some of those harder plastics could be disrupting to that site. You'll also get, when you're in the hospital, one of these little bands. You'll have a band and your baby will have a band. The baby's one usually goes around their foot and yours will go around your wrist, and they match. And so the reason for this is a safety measure to make sure that your baby does not leave with anybody but you, and that they don't leave the unit before they're supposed to. So these are really great as well. You'll probably have some kind of fabric like this that they used to hold on the monitors on your belly. You can, a little trick of the trade, you can cut circles in these like this and just wear it like a tube top. And the nice thing about this is that if you're pumping in the hospital at all, or when you get home, you can use these, the ends of your breast pump, and stick them through here like this. And they gave me a couple of these bands at the hospital, so grab extras if you can. And now you have this hands-free, if I was writing this, it would work. You have a hands-free pumping situation, and that's really awesome because there's nothing more boring than sitting there for a half an hour and not being able to use your hands because you're just stuck like this. So that can be a great tool for you as well, and they are super comfy. They're not that stylish, so if you want to do this with a little cami tank top or something, that's a great option too. After, I don't have a good example of a medium-sized pad, but they're you can get them at the store that are probably about this size, and you'll transition to those in the days after having a baby. You'll start really heavy, and then it'll start to fade out, and you're gonna bleed probably up to like about 6 weeks. Sometimes you stop a couple weeks earlier. I think I bled for probably about 2 weeks, and then it really faded away. But some people do bleed a lot longer. I ended up just using these little panty liners after about 3 weeks or so. So definitely stock up on some pads and figure out which ones you like. Sometimes the ones with the little fans on the side can wrap around and stay on there a little bit better. So just figure out what is comfortable for you. Also, in the hospital, they'll probably have a pump for you. I had a Medela at both of the hospitals that I stayed at, and then I have a Medela portable pump. You can use these as they have the portable ones that have battery operated. This one you can plug into the car charger. I really, really like this brand. It was the most effective of the breast pumps that I've used. I also recommend that you get some of the, most of the hospitals have these. They're like these little square cubes and they're kind of like jelly. And you put them in the refrigerator. You don't have to, but I like to. You put them in the refrigerator and they're really cool. And as you're breastfeeding, your nipples will start to get kind of chapped or sore just in the beginning. You'll eventually get used to it. But before you're used to it, they get kind of chapped and they can be really sore. And then rubbing on your bra and stuff hurts. So these go and they're almost like a little sticker. And the coolness of them is so relieving. And I really, really like those. I had a hard time finding these, and I was able to find them at Target. So, tip of the trade there. And then while you're at the hospital, they usually give you these little syringes. You can get them at most drugstores. This doesn't have a needle, but it's like a syringe for milk. This is a great way of measuring how much you're giving your baby. And in the very beginning, you probably only get colostrum. Your milk's not gonna come in till usually about day 3. So in the beginning, it's just this kind of yellowy colored milk, and that's called colostrum. And it's only gonna fill up just a little bit. And you might initially feel like, oh, my baby's not getting enough food. I'm not producing enough, and it's no, your milk's just not in yet. And your baby doesn't need that much yet. The baby's tummy is initially very small, about the size of an almond or a small marble. I have a little demonstration here. So they're about this big. So they only need this teeny little bit amount of milk. And then over, a couple days and weeks, your baby's tummy is going to grow into, this is a ping pong ball. It's going to get larger and larger. And so your baby's tummy is growing with your milk supply. And that's not to say that there isn't the risk that you're not producing enough, but just know that breastfeeding works on a supply and demand system. So whatever your baby is demanding, your body is going to start producing that. So if your baby's only suckling a little bit, it's only going to make a little bit. If you're constantly nursing, your body is going to be constantly trying to refill that supply. So the biggest tip that I have for breastfeeding is, to do it constantly and to do it frequently. And if you are feeling like your supply is pretty low or that your baby isn't seeming satisfied, then being able to alternate, feeding the baby when you can, and then in between feedings, pumping, so that you're constantly stimulating your breast, and it's telling your body, I need to make more milk, I need to make more milk, and replenish this milk that was just depleted. And so, of course, for true breastfeeding advice, I recommend that you talk to somebody who's like IBCLC certified or a lactation consultant or nurse. But my uncertified advice would be to just nurse as much as you can. And alternating breasts is good too. It's not uncommon to have one breast that makes more milk than the others. So don't be surprised if you notice that. After your milk comes in, you'll probably find yourself leaking, or you're sitting on a bus and somebody's baby cries and your breast will start to leak. This is totally normal. I recommend that you get some of these breast pads. They're really nice. They unfold like this and they have these little stickers on them. And so you just plop these right into your bra and you just cup them underneath your breasts like that, and you can't even tell that you're wearing them, so don't worry about that. They're soft. Again, you can put these little jelly things in there and they don't stick to them, so those are great. I recommend you get some of those. I also want you guys to check out some different types of bags. Some of them are easier to write on. If you're planning on donating or storing milk, the general rule is that milk is good for 4 hours left out, and 4 days in the fridge, 4 months in the freezer. So dating it is important. And if you are going to donate milk, there's lots of different rules with that. So you'll have to contact whatever milk bank and figure out what their specific policies are. Um, but again, most of them require that you store your milk in these bags and label the amount of ounces too. And that's good also because you're able to gauge how much you have stored up and how much your baby is eating. So these are really great. I like the ones that have like a fold on the bottom where they kind of open up so that they can, it's hard to see how this one kind of wise open. So that allows them to stand up in the freezer, and I really like that. Other people I've seen kind of lay them flat in the freezer so that you can store lots of them. So that's a good option as well. The last thing that you will need is a good nursing bra. They come in all different styles and cute lacy ones and all kinds of things. I really liked this one. It had spaghetti straps, very much like a regular bra, so I could wear it to work and whatnot. But the actual cup part of it is kind of the stretchy texture of like a sports bra, which was really comfortable. And that's nice because it you can sleep in it and you can wear it for lots of different things. And then they have these little clasps that just undo, and the half of it will fold down so you can nurse the baby without having to take your whole shirt off or your bra off, or like do this one shoulder slide thing, or folding the. Yeah, I mean, you can use a regular bra, but you end up folding your favorite bra's cup right in half and it ruins it. So having a good, comfortable nursing bra. The other thing is that the days of sleeping braless are no more temporarily because your boobs will leak in bed. So having a comfy bra to sleep in that you can put those pads in is really great. So I recommend trying on a couple different brands and styles and finding one that is best for you. A lot of people ask me, what do I bring in my hospital bag? And Pinterest will give you like everything you possibly could need for you and your baby for a 3-week vacation in Hawaii. But in reality, the hospital will have the majority of what the baby needs. They'll give you a blanket, a little shirt, they give you a hat, a nose sucky thing. Any kind of like bottles and things like that are provided while you're in the hospital. They give you some diapers and wipes. And so, again, your baby's going to be taken care of in the hospital. If you wanted to bring a special prop or blanket, most hospitals do some sort of photography session while you're in the hospital. So definitely bring those just in case. Also, you're going to want a couple outfits to take baby home in. I say a couple because although it's only one car ride home, babies tend to leak fluid everywhere. They're always spitting up or peeing or pooping or something on their outfits. So have a couple backups. You'll need a car seat in order to take the baby home, and the medical team will most likely send somebody down with you to make sure that the baby is in fact put into a car seat in the car. Also, the main things that you'll want in your hospital bag are actually for you. You're going to want those comfort items if there was a particular type of music or birthing tool that you wanted, maybe a special ball or a pillow. I loved having my own pillow. I 100% recommend you bring your own pillow because hospital pillows suck. And then also the body pillow was great. I liked having that during labor. I really enjoyed having my own hospital gown. This was just like a little nightgown that I picked up from the store, and it was softer because everybody knows hospital gowns are super comfortable and they make you look really adorable and your butt is never showing. I don't know what it is about those hospital gowns, but every time I turn around, there's some kind of string I have to figure out. My butt's always hanging out. So I really liked having my own. I felt more confident. I felt pretty during this experience. And if you think about it, if you were going to go to an interview, you would want to be wearing your own clothes. You wouldn't want to be wearing a hospital gown that can make you feel helpless or like a patient. Like you are strong and you got this. And sometimes wearing your own outfit can make you feel that kind of sense of confidence. I also recommend that you bring chapstick. As you're doing all this deep breathing, your lips get very chapped, and it's not something that you necessarily think of right off the top of your head to just throw in your hospital bag. So don't forget the chapstick. Also, don't forget your ID and insurance card. They usually ask you for those, um, and they want to make sure that you are who you say you are, kind of thing. I'm trying to think if there's anything else that I just really needed. A hairbrush. A lot of times, especially if you're doing a lot of position changes, your hair can get kind of matted or tangled, and that can be annoying. So bringing a hairbrush. Also, if you wanted to bring a fan, again, just any of those like labor coping type materials that you want to bring for your birth experience. But most of the things in your hospital bag will actually be for you. And maybe a pair of slippers to ride home with. They will give you these super ugly but awesome socks that have like traction on the bottom, but maybe some slippers for the ride home. So the last thing that I want to discuss before we move on to newborn procedures and appearance in newborn care is shared decision making. So this is something that we do a lot in our everyday life, but not necessarily something that we're used to practicing when we're talking to physicians or doctors. A lot of people feel like you just do what they tell you to do, and not that you shouldn't respect the medical advice of your, healthcare provider, but advocating for yourself is important too. And a lot of times patients know what's best for them or know what types of procedures are in line with their personal values. And so, or their personal preferences for this birth. And so, making shared decisions as a couple and shared decisions with your provider all comes from being educated on your options and the pros and cons of all of those decisions along the way. So, there's a great acronym called, some people got BAR, I like to call it BRA. B stands for benefits, R stands for risks, and A stands for alternatives. And there is nothing wrong with asking your provider when a procedure is recommended. We'll use artificial rupture of membranes, or AROM, as an example. So if they say, I really think maybe you would benefit from rupturing your membranes, and maybe you wanted no medical intervention at all, it's okay to pause and say, well, what is the pro here? Well, the pro is that, we think that this labor needs to get moving along, and because the baby's exhibiting some stress, and we think that maybe this will help. Okay, well, what is my risk? We could potentially, introduce bacteria to the baby, or we could accidentally nick the baby's head, or you could, if there is infection introduced, you could get a fever, maybe, a variety of things in that category we already talked about. So in that scenario, you say, okay, well, what are my alternatives to getting my membranes ruptured? Well, we really need to augment labor. Pitocin is an option. We could have you walking the halls. Okay, great. I'd love to walk the halls first, and then now we're back to the decision, if that doesn't work, of Pitocin versus rupturing your membranes. Well, Pitocin is a medication, so maybe you wanted an unmedicated birth. So rupturing your membranes is a better choice for you. Or maybe you don't want to risk introducing infection to the baby, so instead you choose the medicated route. These are all things, you're just balancing what's most important in those scenarios. And I really encourage you to be open-minded in your preferences and in your birth plan to what you will do in the scenario that your ideal birth plan doesn't work out, because your values might change in those moments. So just being able to open that dialogue with your physician and have educated choices. So I want to talk about your newborn's appearance after he or she makes their grand arrival. Sometimes babies have what we call a cone-shaped head. This can be due to any vaginal delivery, not just a delivery that had some kind of vacuum assistance or something like that. It's totally normal. The baby has fontanelles on their head that we call soft spots, And this is because the bones of the skull aren't fused together yet. And that's so that the baby's head can kind of flex a little bit as it passes through the birth canal. And so sometimes as it passes through, we see the head kind of stretch out and create a cone shape. And this is totally normal, usually goes away in a couple weeks, sometimes even a couple days. So don't be too worried about that. Also, let's talk about the baby's eyes. So you have been waiting for so long to figure out what your baby's going to look like when he or she arrives. And even once they get here, sometimes it's a mystery. If your baby is born with brown eyes, they will remain brown. But if your baby is born with blue eyes, it could be a guessing game for up to a year. So they can change colors, and maybe you'll be one of the few who stay blue, but they can eventually turn green or brown as well. So I also want to talk about the baby's skin. So you'll notice that your baby is like a peach and covered in soft, fuzzy hair when the baby's first born. This is called lanugo. And also the baby is most likely going to be born with something called vernix. And that is kind of like a cream cheesy type texture on the baby. It used to be standard to wash this off, and now it's not. They do kind of wipe the baby down, but there you'll see some remaining particles on the baby's skin, and they don't give the baby a bath right away because that's supposed to absorb into the skin and keep the baby's skin nice and soft. Your baby was originally in a water-filled pouch, and now as they're subject to drier air, the vernix is supposed to protect them and kind of help moisten their skin and make that transition into our world a little bit easier. I just want to talk about birthmarks. They are normal. Some babies are born with discoloration on their skin, and sometimes they stay, sometimes they fade. We also see what some people call skin marks, where the baby will have marks on their forehead or off to the side of their face, sometimes on their eyelids. These can be permanent, but usually they fade within a couple months, sometimes a couple weeks, and there are a few times that they stay permanently, but usually they fade. And we also hear them called stork bites. So if you see those, don't fret. There's also what we call milia, which is kind of like baby acne. You'll see like lots of little bumps that are white, and this happens to the majority of babies. And their skin's just learning how to make extra oil because of the baby being subject to this drier environment, and so their skin is just learning to adjust. It's also can happen from the extensive exposure to hormones during birth, and so another thing we see too, due to the hormones at birth, is swollen genitalia and sometimes swollen breasts as they're, just under intense hormones during the birthing process. And this will fade and then will return to a normal size. So these are all things that are normal, not things to be concerned about. If you do feel concerned at any point, of course, call your medical provider and double check that something is not abnormal. Another thing we should probably talk about as far as newborn appearance goes is their belly button, or if your baby had a circumcision. So circumcisions are done a couple different ways. The two that I'm familiar with are where they completely cut off the foreskin, and one where they put like a cap over the top and they tie a string around it and make it really tight so that the foreskin will naturally fall off due to the cut off circulation there. And however, both of these are pretty standard, it sounds like to me from what I've experienced. And as far as care for the circumcision site and what looks normal and what doesn't, we always recommend that you talk to your healthcare provider and they will recommend the same thing to you. It'll be read at first, but in order to protect from infection and things like that, definitely stay in touch with your healthcare provider. As far as the belly button goes, after they clamp it, they leave a little clamp on there and it will eventually dry out and fall off. There are lots of mixed information about whether or not you should submerge the belly button and get it wet or whether you should keep it dry. It is okay to give your baby a bath and for it to go wet, but you really want to make sure that you dry it super good afterwards because we don't want any kind of infection or bacteria to grow in that moist, wet environment. Just like any other moist, wet environment, our mouths or the vagina, they're a habitat for bacteria. So it is okay to get it wet, but make sure if you're going to that you keep it super dry afterwards before you put the baby's clothes on, just to avoid that bacteria growth. And the other thing, your baby is going to be super, super cute and tiny. So if your baby is really small or if your baby is a little bit chunky, these are also normal things. Your healthcare provider will usually give you some kind of grade as to what percentile your child's in and what's normal growth for that um, baby size. But we do normally see that when the baby is born in the first couple days right afterwards, usually the next day, the baby's weight will drop. This is normal. Your baby is going to be having bowel movements and expressing, sometimes they puke up amniotic fluid, all kinds of things that make the baby's weight drop a little bit, and it will, rest assured, it will go back up. So again, something that is completely normal. After the birth of your baby, there's a couple of procedures that are pretty standard. One of them is skin to skin contact. So we place the baby directly on your chest without any blankets or clothing separating the two. This helps the baby for transition from life inside the womb to life outside the womb. The baby is able to hear your heart rate, and we've noticed too that it helps regulate theirs. It also helps regulate blood sugar levels. It can help regulate body temperature, especially if you have a child that's born early. This would be really important to help keep the body's temperature regulated because they have a little bit a harder time around that 35, 36-week mark. After that, the babies do a little bit better regulating their own temperature, but either way, it's still a great procedure. It also helps with bonding. Just having that moment, like this has been an intense thing, you've been waiting forever for this, and gets the pheromones flowing. So skin to skin contact is wonderful for all of those above reasons. It also helps them do better with breastfeeding. I'm not exactly sure why that is, but we do see that across the board statistically that babies who have skin to skin contact directly after birth do a better job of breastfeeding right off the bat. If you can't do skin to skin for some reason, maybe you had an emergency cesarean or something along those lines, or maybe it's not culturally appropriate for you to do a skin to skin situation, rest assured your baby can still breastfeed and everything will be okay. It just can help a little bit in the beginning. So other newborn procedures that are really standard, sectioning their nose right away or their lung, you'll see them put it in their mouth, looks like this. And sometimes babies swallow amniotic fluid or other fluids when they're coming out of the birth canal when they do their first cry, and sometimes they inhale it. That can be normal. And so they'll try to suck it out right off the bat in order to prevent that fluid from sitting in the baby's lungs. And that's why they're also looking to make sure the baby can cry afterwards, make sure there isn't anything in their lungs. The APGAR evaluation, this is just evaluating your baby's oxygen levels, things like that, and their color, different things in order to see how the baby is doing overall. We weigh and measure the baby. This usually takes place after an hour of skin to skin contact, so they're not going to weigh the baby right away. You won't know how big your little guy is or little girl until after that initial period. And if you have a cesarean, sometimes they take the baby over to the scale right away if you're not able to immediately do skin to skin. So it'll just depend on the birthing situation and maybe your hospital's standard procedure time. They also do the antibiotic eye ointment. This is to obviously prevent infection from bacteria that grows in the vagina as the baby is passing through the birth canal. And so it kind of, there's a little bit of oily cream on there, or ointment, and your baby's eyes could be a little bit swollen too, and that's normal. You can opt out of that if you don't want your baby to have the antibiotic ointment, but it is a pretty good idea. The vitamin K shot is also a common procedure that they do with newborns, and that helps your baby's blood to clot and can be a beneficial procedure. We also do the hepatitis B vaccine. That helps the baby prevent any kind of damage to the liver, which can later cause cancer. So that vaccine's great. If you want to wait on your vaccines, you can, but it's recommended that you do them at the time of birth. We also do hearing screenings, and I haven't had them do a vision screening on my babies at that newborn stage, but I know the hearing screenings are very standard. They also do sometimes they do a car seat screening if your baby is born early. I know with my surrogacy baby, she was born a little bit early and she was so tiny. So they had her in a car seat simulator to make sure that she was big enough for the car seat. to actually keep her safe. And if your baby is too small, maybe you have a premature baby, they're going to help you and give you some tips and different ways to transport the baby and to make the car seat safer for them. And so they want to make sure that you take this baby home in a safe environment. So that's not standard, but it is if you have a very small infant. They're also going to do a birth certificate where you write the maternity and paternity information. If you want a paternity test, they can do that in the hospital as well. You do have to pay an additional charge for that, so it's something to consider. And then I think they also do a bath sometimes. So I was sent home last time with a baby without the baby being given a bath. And 3 years ago when I had my son, they gave him a bath. So I think it's a newer procedure again to keep that vernix on the baby to help the skin adjust to this new environment. But if you want one, you can request a bath. And they usually do like a little sponge bath there in the hospital for you if you want that. So those are the typical procedures. This is Dawson, our little helper. This is my nephew. He's 4 weeks old now. So he's going to help us demonstrate a couple things during our newborn class today. I want to talk about some different reflexes that your baby might exhibit over the first couple months of life. One of them is called the Palmer reflex. And so this is when you touch your baby's hand, the palm of their hand, and they instantly grab you in a little fist, just like that. Another one is called the rooting reflex, and this is really important when we talk about nursing. If you rub the side of your baby's cheek, they will turn and start to suck. As you can see, he's looking for a nipple. That's really great when you're learning how to breastfeed. We talk more about that later. There's another reflex, and that one is called the sucking reflex. And anytime you touch their mouth, they start to suck. It's an automatic reflex if you put a binky there, your finger there, if they put their toes in their mouth. Another reason why it's important to watch what we're giving our little newborns, because everything goes in their mouth and they instantly start sucking on it. So making sure it's something that can be in their mouth and something that's soft or something that's meant for babies. Another reflex we have is the Moro reflex. And this is something when the baby is laying down, usually when they're sleeping, and there's a really loud noise, like we drop a book or something. The baby will go like this, and oh, honey. And I won't startle him to show you that, but you would see their hands fan out like this. And then we have the Babinski reflex. This is when if you touch the baby's foot like this, their little toes will fan out, if you can see his foot fanning out. And so that's kind of a cute, fun one. And then we have the step reflex. And if you were to hold your baby up in this position, they will curl their legs up just like he's doing. And that's the instinct to try to walk, to try to step. And of course, he's not quite big enough to learn how to do that yet, but it comes in handy later. And then we also have the tonic neck reflex. So if you were to lay your baby down, whichever way their baby's head is laying, you'll notice that whatever way their head is facing, this arm will tend to come out, and the other one will curl up into a little nut. So I want to talk about your baby's senses. So your baby has been able to hear since like mid-pregnancy. We actually see some studies where newborns prefer the sound of their mom's favorite TV show for the intro song, things like that. And they do recognize your voice and oftentimes other people's voices who are around them. And I know that sometimes in our surrogacy groups, we have people who have the parents, biological parents will record their voice and they put little headphones on their bellies so that the baby knows their mom's voice when baby's born. So this is a thing, and use it to your advantage. Talk to your baby, sing to your baby, things that you may have, and you can even do that while you're pregnant now. Sing your favorite lullaby to the baby, and so that they're, used to it when they come out, and they're so excited to hear you. They do a hearing screening too to see how the baby is receptive to sound and octaves. So be prepared for that again. And then also for the baby's vision, this is actually the least developed sense, which is surprising for most of us. We want to see them and look at us, and um, they can see, but it's harder to focus. Probably about like, I think it's 8 to 14 inches away is what they're able to focus on. So if something's really close up, they have a hard time. But about what you would hold your baby, like the standard distance, like, oh, you're so cute. This distance is good for them. They can kind of see the dark areas of your eyes or dark area of your mouth, and they can kind of make out some contrasting facial features. So, and that's why when you look at these baby toys, you see a lot of black and white contrasted toys. Or if you were outside with your baby, then being able to see the difference between the leaves and the trees and the light blue sky. Anything that's really drastically different, because the vision is a little blurry at this time. So anything that's really contrasted is easier for them and will help with their vision development over time. So a great way is to interact with this particular sense would be to get some mobiles that for their crib, or sometimes people put little toys on their car seat. Not too many, you don't want to overstimulate your baby, but something just for them to focus on as their vision develops. Um, Also, smell and taste. They can actually smell pretty well. They can smell your breast milk when they're on your skin and be able to kind of locate you that way. That's also why your areolas are so dark, again, to create that contrast for the baby to find your nipple using vision. And they can taste your breast milk. They notice differences between the taste of breast milk and the taste of formula or the taste of somebody else's breast milk. So that's really interesting to me. Um, but again, and with the touch, they love it. They need this touch in order to grow. So just like we like to be cuddled and loved, so do they. And when sometimes your baby will cry, and you try feeding them, and you try changing their diaper, and you check for gas, and you're just like, why is this baby crying? And sometimes they just want to be held. And this is not your newborn being needy. Anything a newborn wants is something a newborn needs. It is not like a toddler who is whining for something that they don't necessarily need and they just want it. When newborns cry, it's something they need. And sometimes the thing they need is to be held. And this touch actually stimulates them to grow. And we see that babies who lack touch, or babies that are left unattended for long periods of time, actually can exhibit failure to thrive symptoms. And not to say that you have to hold your baby 24/7 all the time, but it is important for their growth and for them to get their hormones and things flowing that allow their body to continue to grow and for their mind to develop. So when you hold your baby, know that you are doing something great for their development, and that you're not creating some kind of dependency. We actually see the opposite, which is that infants who are nurtured and responded to right away when they cry tend to be more independent later in life, because it builds trust. So even when you're responding to your baby and you maybe don't know what's wrong and you're trying all these things, they're still building trust because you're trying, you're there, you're responsive, they know that the help is coming. And kids that learn that early on, that when mom is here or when dad is here, they're going to help me, and eventually you're going to figure out what's wrong, and they're waiting for that. So later in life, when they're a little bit older and something's wrong or they call for you, they know that you're going to come, and they know eventually the help will arrive. And so a lot of times when you respond to your baby later, they will stop crying because you're here, and they'll wait for you to make that bottle. Babies who aren't responded to right away, where we just let them cry or they're left alone a lot, they later, when you go to make a bottle for them, we see that they continue to cry, because even though you're making it and even though you're there now, they aren't sure that you're going to help them necessarily. And so they will just continue to cry and cry and cry until the bottle's in their mouth, or until that thing that was their relief is there. So we actually see the opposite. The babies that are left to cry it out are more dependent later on you than babies who were responded to initially during this very important newborn stage. And again, this is very different than toddlers. So newborns sleep 16 to 18 hours a day, which is a lot out of a 24-hour period. And you're probably wondering, if they sleep so much, how come everybody has told me that I am going to be up constantly, that I'm never going to sleep again, which is probably true, by the way. The reason for that is because they sleep in short increments. They sleep in increments of like 1 to 3 hours max, sometimes like 15-minute increments. And you'll see, and the levels of sleep are a little bit different, but they sleep in these short bits. And so when you have a newborn, it's really important to sleep when the baby sleeps, because they are going to be up every couple hours to feed. And this is because they have such small little tummies. So your baby's tummy is just the size of a little marble, or like an almond when they're first born. And so they can only take a little bit of breast milk at a time. So even in the beginning, when you feel like you might not be making very much milk, or you just have a little bit of colostrum, that's because your baby doesn't need that much at a time. Their little tummy is so small. And this is also why they're going to wake up every 2 hours to eat, and why the hospital will recommend that they eat every 2 hours, because they need that little bit of nutrition to grow, and then it gets metabolized really quickly, and then they need some more to grow, and then it gets metabolized really quickly. Over a couple of weeks and months, your baby's stomach will grow a little larger, into about the size of a ping pong ball. And so then you're going to start seeing your milk come in, and you're going to be making more, and your body is going to respond and make more as the baby needs more. It's a very great supply and demand system. So that is why the baby is waking up so much, and we encourage you to sleep when they sleep, so that you have the energy to make that milk and to get up with them when they need you. There's also some ways that you can help yourself get some rest with the baby during this time period, and that is to room share. So we actually find that it's best if the baby sleeps in a separate crib or bassinet, or if you really want to co-sleep, getting like they're like bed sharers. They have like a little barrier that, so that your blankets and bedding can't get onto the baby, and also so that you don't accidentally roll over on the baby and potentially suffocate the baby. So they have all these different options, but it is best if the baby is in the room with you, so that you can have a quick response time. So again, your baby builds that trust and will cry less. And also so that you can breastfeed maybe with your eyes closed a little, just kind of rest through it, keep the lights dim, so that the baby goes back to sleep quickly after feeding, versus, oh, the baby's awake, engaging the baby and starting to play. I mean, you're not going to be able to sleep train this infant, but you can try to create an environment that promotes falling back to sleep quickly. So keeping the lights off, keeping music either really soft or none at all. If you have white noise like a fan, that can be beneficial for both of you to relax. What is important though, if you're going to keep this really relaxing environment when you're super exhausted, is to try to stay semi-alert when you're breastfeeding. You don't want to fall asleep breastfeeding and then accidentally roll onto the baby or something like that. So I found with my personal pregnant or newborn experiences, that if I sat in like a reclined rocking chair or got myself up, it was still relaxing for me enough that I was able to fall back asleep after I was done feeding the baby. But that upward position or sitting upright in your bed was hard to fall asleep in. You know, your neck kind of gets kinked and stuff. And so although it's relaxing, it's not going to make me fall asleep. So that's just my own personal tip for you. So also we see that if you want to get your baby to adapt to a normal sleeping schedule, keeping their naps during the day and maybe a well-lit room from the windows, or keeping noise levels normal during the day. You don't have to make the house super, super quiet during the day because the baby's napping. You know, we can kind of see that shift, that if they rest a little lighter during the day, that they might sleep a little heavier at night. So those are just some tips or ideas to keep the environment like a true day environment, and keeping the night quiet and dark like a true night environment. And over time, your baby will adjust. Again, we don't suggest like an intentional sleep training at this early newborn stage. So we talked about when your baby is asleep. Now let's talk about when your baby is awake and the different levels of alertness. We have like quiet alert, where they're calm and awake. And this is kind of when your baby's eyes are bright and they're interested and they're kind of ready to learn. We have like active alert, and that is when they're awake but they're fussy. There's something wrong. They're flustered. They're very much exhibiting, outward energy and are looking for responsiveness from you. This can also happen if they're overstimulated. They can kind of get fussy. So really, the time to engage with your baby is, if you're looking for bonding experience, something like that would be when your baby's quiet and looking around, that like quiet alert stage, and they kind of are receptive to lots of engagement there. You can stick your tongue out and they'll try to stick their tongue back at you. As they get a couple weeks old, you can start to smile and they'll smile back at you. And so that can be really fun. They can also get kind of drowsy when they're awake, but their eyes are like slits and they can barely hold them up. Their eyelids are heavy. They want to go to sleep. They can fall from this into like kind of a very like active sleep where they're easily startled because they're lightly sleeping, and that can happen in those little naps. But there is a point where they reach this really like quiet sleep where you could drop, something really loud and they are just like out. So you'll see them, they're not really moving. During this really quiet sleep though, some people get like little oxygen monitors for their baby's feet. I didn't have one. You can if you want. They do sometimes have like a couple seconds where they stop breathing and then they start breathing again. And it's kind of like, and you'll hear them start back up. If you were to notice that your baby stopped breathing and didn't start again, obviously, you would want to call 911. But these little tiny periods where it's just a couple seconds, that's normal. So don't be too afraid of that happening. Babies do go through this period of light sleep and active sleep about every 30 minutes. So waiting until they're in that deeper sleep where you don't see their eyelids moving, and you don't really hear them cooing or anything in their sleep, that's a good time to move them where they aren't going to startle awake. So just a little mom tip there. And again, this deep sleep or quiet sleep is good for their muscle and bone growth. So we want to let them rest in order to promote healthy growing. So it is normal for your baby to hiccup and to sneeze. So your baby might have even had hiccups in the womb, so this is normal. The babies sneeze a lot to get like particles from the air out of their lungs, just like we sneeze sometimes. So that's totally normal. What's not normal is if the baby is gagging. So a little bit that can happen if they spit up, especially if they're laying on their back while they're feeding. They can gag a little, and it's good to lean them in an upward position and kind of pat their back, or sometimes you can even use one of these syringes again, and as they cough, try to suck at the same time and get that fluid out of their throat. If the baby continues to gag though and it becomes like a choking scenario, you want to flip the baby over on your forearm, just like I was showing, and patting the baby's back this way with its face down so that it can get that out. And of course, if you were concerned for the baby's safety, you could call 911. So I want to talk about positions on how to hold your baby. When they're newborns like this, they can't support their heads by themselves. The muscles in their heads aren't strong enough to hold the weight of their head, which is the majority of their body weight right now. And so how we position them is really important. If you're walking around the house, I recommend this kind of cradle hold. Your crook of your elbow here is going to support the baby's neck, and you can either hold one of the legs. Oh, that is good. You can hold one of the legs like this for extra support, or also you can kind of hold under his butt like this. But I like kind of having a little bit of a hook on their leg just for extra security. This is great, like I said, for walking around. You can even nurse in this position. If you have a shirt that's available that opens up, you can even do it without changing your shirt, which is great. Another position that I like, I think it's great for bonding and also good for walking around, is this position. And notice that I'm holding the back of his head when I transfer from different holding positions. So you hold them like this, and you're able to kind of have their head rest against your chest. And again, always keeping your hand on the back of your head, because you'll notice they try to wobble like this. So I like to hold their head As they get stronger, you won't have to necessarily hold them as much on the back of their head, but definitely during the first couple months while they're in the newborn stage, it's always a good idea. And then also, I like to sometimes turn them a little bit facing forward so they can look around. If you're walking around, or especially if you're outside, they like to look around at the trees and things like that. Occasionally, you'll see people hold them in what we call a football hold. Um, that's when you do it like this, and you, again, I'm transferring using my hand behind his neck, and you kind of push them, you cradle their head in your hand, and you're holding between your elbow and the side of your body, like you would very much carry a football. This is more of a position for nursing and not a position for walking around, just because it's not very stable. I recommend doing it while sitting down. And then we have another position that we do when we're burping and sometimes during CPR. And again, we want to hold the baby's face when we transfer them down so that we don't drop their head. And they can use this for burping. And I guess not the baby's face, but just supporting the head a little bit. So I have another little helper here. This is Scarlett. She is now 2 months old. And I want to demonstrate another way to hold your baby that is great for a little bit bigger babies. So you can hold them this way where they sit on your hand, and you kind of wrap your arm around the front of them like this, and they can look around, and they can wiggle and move their hands and their legs. She's got a little bit more head support now. I still try to keep her supported because she's a little wobbly. But I want to demonstrate how you can hold your baby with a boppy. So once they get big like this, they are heavy, and especially if you're carrying them around all the time. And so they sell these U-shaped pillows called boppies, and you kind of wrap it around your waist like this. And so when you're sitting down, you can use a regular pillow too. It doesn't have to be U-shaped, but you can rest the baby on your boppy pillow like this. So her head is still supported, and it just gives your arm a break. The other nice thing about these boppy pillows are that they kind of create like a donut, like a cushy donut. So for any of you mamas out there who are concerned about tearing or who have already experienced that before in a previous pregnancy, if you were to tear, sometimes sitting down can cause pressure on the site of the tear and be painful. So sitting on a boppy relieves that pressure around the vaginal area. The other way that you can hold your newborn and a little bit bigger baby is in a position where I sit on my bottom, I put my knees up, and you lean the baby against your knees. Babies like their heads to be patted like this. And that allows you to engage with the baby a little bit and play with them, make faces at them, and just to have a little bit of quality bonding time. So that one is good for all ages. You can also do that in the bathtub. If you choose to take a bath with your baby, putting your legs up and letting them kind of rest in the crook of your legs is a great way for them to interact with you and play in the bath together. Another way that you can carry your baby around would be in what we call an infant carrier. They have different types of packs. There are hard packs, fabric packs, sling packs, all kinds of different baby carriers. They come in handy when you are hiking, if you're doing any kind of household chores where you need 2 hands, doing the dishes, folding laundry. My baby pack saved my life, so hopefully you find it as relieving. I have a couple different ones to show you. So my favorite type of carrier was my Ergo baby. I've tried lots of different ones. This is one that you would buckle around yourself. I like this one because it's got a really thick padding that rests on your hips, and so it doesn't put so much weight on the rest of you. And because it's got such a wide strap, it's not really, really tight. It kind of disperses the weight of the baby, and it can grow with your baby. So I used this until my son was about 3. And so this one has a buckle. I kind of tuck this in. This is great for if you have someone else to help you with a newborn. You could put them on your back like this, and you would put them in, and they'd rest up against your back. I don't like doing that with a newborn. With my newborns, I like to spin this around like so and carry them on my front. It lets me, I can nurse in this position, but it also lets me see the baby. And so I can monitor the baby. If the baby's spitting up, I can monitor the baby's breathing. There's a closeness, they can hear your heartbeat, they stay more calm. So I really like this position. I also feel more protective over this position. If I was to trip or something like that, I feel like I can kind of block the baby a little bit with that. So actually, with newborn infants, they come with these little inserts if you want to use them. I didn't always use mine. They have like a little pillow on the bottom that just lifts them up so they're a little bit higher up. I can show you both ways if you want. So we put this in here like so, and then you would wrap it around. Stay there, little guy. Stay there. While always watching your baby to make sure that they don't roll away. Babies that can't walk, surprisingly, can move very quickly. So I like to buckle it after I have the baby in, so I'm going to leave this part off. And then I'll pick him up again, always supporting the head when I transition his positions. And I kind of slide him down into the carrier. Again, supporting that head. Okay. You're okay, buddy. You're okay. Here's your little baby. I'm kind of bouncing him just to calm him down a little there. Okay, so then this is where you would take these buckles and you snap them together. I like, when I'm doing it myself, I have to loosen it up a little and put the straps on it, and then I just tighten it back up like that by pulling. If you have somebody else to help you, you can just put the baby and hold him here and let someone else buckle the back. So this is a really great nurturing position. Sometimes you can turn them a little bit to feed them in this. These are just covers. If it's really sunny out, you want to protect the baby this way. We don't usually recommend that you put sunscreen on a tiny baby, so just blocking them from the sun is great. A lot of the hard packs also have like little umbrella covers, and those are great too. So this is one way you could wear this pack. Again, like I said, you could switch them onto your back. Lots of the other Ergo baby carriers have like 3-in-1 positions, and you can turn the baby face forward so that they're still on your front, but that they're facing outward, and so they can look around. Your baby needs to be able to hold its head up a little better for that position. So I wouldn't recommend it for a tiny newborn. But that one is great. And in that case, the legs would come out here. And I'll kind of show you a different pack that I have that you can use that position in as well. But again, this was my favorite one. It had really thick straps too. And so just more comfortable. And it fits a variety of sizes, and the babies love it. And you can take the pack insert out as they get bigger. So that's a great option too. So when it's time to take the pack off, we will use one hand again like this and clip it and undo that. And again, I'm always holding one arm on the baby because now that the support is gone, I don't want these to slide off and the baby to come with. So I'm going to always keep one hand on the baby. Now I'm transferring, again, supporting the baby's head to take him out of the pack. And now I'm holding his weight. I still have one strap holding up the baby's bottom. And I'm sliding my other hand inside here, as you can see, under his back to take him out. And it'll fold down. And then you can either set your baby down or put him into a cradle hold here while you unbuckle the rest of it to take it off. Another carrier I want to talk about is called a sling carrier. Kind of like an infinity scarf. You can fold them in half, or you can buy a carrier and they're 2 separate rings like this. Where they're connected, you're going to want to line up the rings and put them around your neck with the connection resting on your neck. And then you're going to want to separate the 2 rings, and you put an arm through each one. So you're going to put an arm through this one and an arm through this one, and it'll make an X across your chest. These types of carriers allow you to walk around the house hands-free, do different tasks, go on walks. I don't recommend them for any kind of long distance hiking where you would want a lot of back or hip support. They don't offer that. They're also really great though for feeding your baby, or for whether that be breastfeeding or with a bottle, or for kind of bouncing them around a little bit to rock them to sleep. So I'm going to show you one. I like to widen it out a little bit, the fabric pieces like this, before I try putting the baby in there, because sometimes these carriers can be a little bit difficult. So then you would put the baby in this area right here, and either the baby's legs can come out this way and face forward or backward depending on the age of the baby, or you can lay the baby this way in order to feed, or in a laying down cradled position. So I'm going to show you both. And when we pick up the baby, we'll always support the head, and then I'm going to kind of curl them up. Little babies are super bendy, and I'm going to put him right into the center of this wrap and constantly holding him for support. So I'm switching hands, but still supporting his head. Tuck this under his bottom a little bit like that, and then around the other shoulder. And so this, oh, little guy. So this allows me to kind of bounce him around like this. And he's nice in there in a little nook. And it crosses your back like this around both shoulder blades for comfort. If he was a little bit bigger, we could have his hand can come out here and his foot would come out on this side and another foot would come out on this side like this. But he's really little, so he's still bundled up in a ball. I'm going to show you another position for this wrap. To get him out, I like to go underneath this way, and that way I can tuck my hand underneath his neck in order to pull him out. And then I switch back out. Whoa. All right, little guy. You're okay. Do you want your little bink? Okay, so we have another way we can do this, where we kind of pull it to one side and we create a sort of sling for the baby to lay in this way. So I'll show you that. Okay. And again, I kind of start with his little bum and I tuck it into the sling and support his head in there and switch to a cradled position. And then I tuck his feet in like this. And it creates kind of a cozy little nest for him. So you can see this would be a really great position for breastfeeding, or for bottle feeding, because you could feed them this way. For removing the baby out of the sling, I kind of open it up like this, and I just tuck my hand underneath his arm, supporting the back of his head like this, and then I pull him out, grab his bottom, and pull him out the rest of the way, just like that, and returning to a cradle position. I'm going to talk about newborn infant crying. It's something that's kind of intimidating to most moms in the very beginning, but it's also totally normal. And there's so many ways to help this and identify different types of cries. So let's talk about that to alleviate some of that stress for you. Let's start with why babies cry. There are lots of reasons babies cry. They cry because they're hungry. They cry because maybe they need to be burped and they're feeling gassy. They cry because they need their diaper changed. They cry if their clothes are wet or uncomfortable. They cry if they're too hot or too cold. They cry because they want to be held. They can cry because they're sleepy and they don't know what's happening to them. They're just tired. I want to cry when I'm tired sometimes. They cry if they're feeling sick. And they can even cry if they're bored, like if they just want to be engaged with. So lots of reasons for crying. We also see that in the newborn stage, they're not so bored and they're a little less aware of things. Some of their senses aren't as developed, so they're not as overstimulated. So they cry actually a little bit less as a very teeny newborn and they're sleeping a lot. But as they get older and more alert and their senses develop, around 2 months, we actually see that the crying increases. And so sometimes this is concerning for parents. They feel like, oh my gosh, all of a sudden my baby cries all the time. I don't know what's going on. This is totally normal. We see this, rest assured, it will start to fade again as the baby gets older and learns that trust, the responsiveness, and they self-regulate a little bit too. And you're more familiar with your baby's cues and what type of cry, you'll learn what cry is, what goes to which problem. And so at 4 or 5 months, we start to see that fade back down again. So there's a light at the end of the tunnel. Some comfort techniques. I mean, most people are very familiar with rocking the baby, standing up and kind of bouncing them. These are going to be your best friend. If you sit on one of these balls and bounce that baby, I don't care if that baby is hungry, if that baby's tired, these are great. They temporarily, and sometimes more than just temporary, can relax the baby enough and kind of simulate the rocking that your baby used to have when they were in your belly and you're walking around all the time, and it relaxes them at least until you are able to figure out what's wrong and solve the problem, or bouncing the baby until your bottle's ready, or maybe while you change if the baby's diaper needs to be changed and you're getting the supplies together, dad can kind of rock the baby. And so that's a great motion way uh, to relax the baby. There are also other ways that we can use movement. I mean, you can rock the baby side to side. There's swings that go forward and back. We just talked about bouncing, taking out the baby for a walk. Sometimes, surprisingly, just walking outside. I don't know if it's the temperature change or just a different environment, but just going for a walk around the house or a walk outside seems to really relax infants. I do this a lot, and people think I'm a baby whisperer. They just want to be moved. They want some engagement. Maybe they're sitting in their swing, and even though it's moving, they're staring at the same toy or the same spot on the ceiling or whatever. Or maybe when you're holding them and bouncing them, maybe they're getting too hot. So sometimes just going for a walk around the house or walking outside is a great way to make the baby stop crying. Some people also, I have heard, have put their babies in car seats where they're safe, and like up against a dryer or something that's vibrating to create that sense of movement as well. Lots of babies fall asleep in the car. It is not uncommon to hear of moms and dads who are just exhausted who put the baby in their car seat in the car and go for a drive. I haven't intentionally taken my baby for a drive to put the baby to sleep, but every time I get in the car, my baby falls asleep. So it is definitely a thing, and sometimes it's a last resort. I don't recommend you drive if you're so exhausted that it is a danger to you, but if that's what gets your baby into a really deep sleep and you're just at the point where you need a break, mama, take a break. Go for a drive. And maybe that can be a good time for you and your partner to bond and talk, because after you have a baby, sometimes, the baby is the priority and you lack some of that time for you guys. So if the baby is sleeping in the car and you go for a drive, that's a great time for you and your partner to kind of reconnect and reflect on how things are going, and what you like, what you're having trouble with, and be able to communicate together. So that can be a great way to help with crying as well. Physical contact, like we said, holding a baby, trying them skin to skin, putting their head on their chest where they can hear your heartbeat. That's comforting to them. Maybe praying with that sound aspect, playing some light music, something that's got a soft rhythm to it. The babies seem to like that. Sometimes you could put them like in a carrier and face them outwards so that they can see and be engaged again. Kind of goes with the walking thing. You can sing your baby songs. Maybe something that you used to sing to them when they were in the womb or when they were a tiny infant. They like the sound of your voice. That can be relaxing. Obviously, if the baby is crying because it has a dirty diaper or because it's hungry, start there. I almost always start with my boob. I always feed the baby first. And if they're not hungry, they'll just like let go. They're not going to just keep eating because their tummy's only so big. So that's where I start. If there's a distinct smell, I start there. But I usually start with breastfeeding. And if that doesn't work, I check the diaper. And these newborn diapers have a little line down the center that lets you, it's usually yellow and it turns blue if it's wet. And so maybe the baby's wet and uncomfortable. So then I change the diaper. If that doesn't work, I start to rock the baby and try these other types of things. If it's hot, I take a layer off. Maybe the baby's uncomfortable. If I think it's chilly, I don't usually put clothes on the baby in that moment when the baby's frustrated, because the wrestling can be like more frustrating to them. I usually just swaddle them. Like I put them in a little blanket and wrap them up tight. They're warm. And if that warmth and temporary, squeeze and comfort stops it and like, oh, maybe they're cold or maybe they wanted to be comforted. And if once the baby's calmed down, then you can put another layer on the baby. Also, if you do swaddle your baby, we recommend that you keep their hands like a little bit loose, maybe up towards the front, because sometimes they do hungry cues where they put their fingers in their mouth and they suck on them, which can be a good cue for you, but also because they can be able to move stuff out of the way. Um, and it's a little bit more comfortable for them. Make sure their feet aren't wrapped too tight. And we usually only swaddle till the baby's about 8 weeks old. After 8 weeks, they can kind of roll over onto their tummy, and you don't want them to be like stuck face down and not able to move if they need to lift their head and that kind of thing. So we usually only use this for newborns. And if you do swaddle them, well, actually, whether you swaddle or don't swaddle, make sure you buckle them up when you're putting them in a swing or laying them in any kind of carrier that bounces them around, because they can, I don't know how these babies that don't crawl do it. They wiggle their way right off of things, and you don't want the baby to fall, especially in this newborn stage where they're so fragile. So again, swaddling is a great way to calm the baby down, but just take precautions when you do that. Let's talk about what to do when the baby is crying and we're overwhelmed, because sometimes you might be there, mama. Like sometimes the baby is just crying, maybe your baby has colic, and you're just exhausted. Maybe you need a break. It is okay to set the baby down and take a break. If you've been endlessly trying and your efforts seem to be going nowhere and you're getting frustrated and you feel like, oh, make sure you don't do this while holding the baby. We don't want you to shake the baby. It's not actually going to help anything. It's just going to make it worse. It could cause permanent head trauma to the baby. And the baby can sense this negative vibe that you're having, this stress, and you could be, kind of pushing that off onto the baby and making the baby continue to cry. So it's okay to set the baby down and take a minute for you. Like you are important too. And I like to think of this in the sense of a healthy mom. You need a healthy mom to grow a healthy baby. Like, and not just physically healthy, but mentally healthy also. Like it is okay to take some time for you and step away for a couple minutes, collect yourself, calm down, take some deep breaths, practice the breaths that we learn in our childbirth class. If you do choose to stay with the baby or if you walk away, trying those relaxation methods. Sometimes that passes on to the baby while you're holding them. You take some deep breaths together and they can calm down. Sometimes it doesn't work and you just need to set them down and walk away, or call a friend, call your mom, call somebody else in the house to come help you, and maybe they can try something else. Someone who has the energy, who's maybe not as tired as you. Another way to help a baby that is endlessly crying could be a pacifier. There's a lot of mixed opinions, mixed information, and advice regarding pacifiers. Talk to your healthcare provider. I've read a lot of books that say that it can affect your infant's teeth coming in the right way. My dentist told me that that's not necessarily true if the baby doesn't have teeth yet, that we don't really see that. Sometimes nipple confusion. People say if the baby's having a hard time breastfeeding, that staying away from a pacifier or a bottle that it comes so easily to them that's shaped differently than your nipple. However, they have done a great job of creating new pacifiers that are very similar to a nipple shape. And so some babies, though, really just want to suckle and they don't really want to breastfeed, and you'll see them latch on and then they kind of fall off, and you think, oh my gosh, this baby doesn't latch, he keeps crying and he's so hungry. And the baby's not necessarily hungry, the baby just wants to suck, and every time he sucks, milk comes out. And that is what the doctors told me with my first son. My nipples were raw. He wanted to suck so much. And they said, this baby isn't hungry, this baby just wants to suck, you should use a pacifier. So definitely talk to your healthcare provider and see if it's something that is okay for your baby, because it can be a lifesaver. It was for me with my first. Our other one was not a binky baby at all. So again, just seek professional advice about that. So I want to talk a little bit about breastfeeding, and breastfeeding provides optimal nutrition for your baby, as well as help support their immune system and help them to fight infection as your antibodies pass through your breast milk into the baby. It also helps them with bonding. It helps you regulate your hormones. It helps you with what we call uterine involution. So your uterus gets stretched super big, and it has to contract back smaller to its normal size. And breastfeeding um, promotes oxytocin release, just like it did during labor, in order to cause uterine contractions so that your uterus is capable of involuting into that smaller size. So breastfeeding is both beneficial to you and your baby. So we promote breastfeeding. However, I do want to make a quick little statement about formula feeding, because breastfeeding is not always an option for everyone. And I like to say that a fed baby is better than a dead baby. And that sounds really graphic, but I think it's really important for moms to know that, because sometimes formula really might be the best option for you depending on your scenario. And I want moms to go into that stigma free and understand that the most important thing for you as a mom is to provide nutrition to your baby and to make sure that they're taken care of. And that can be provided to your baby in a variety of ways, formula being one of them. But for the sake of this class, we're going to talk about some breastfeeding tips. I do recommend that you take a separate breastfeeding course or lactation course by somebody who's IBCLC certified, or a medical practitioner. But we'll talk about a couple tips for latching on. When you first start to feed, it's not always natural for your baby to latch on right away. So you can kind of squeeze your breast and make it something that's easier to latch onto, versus, especially if your breasts are really swollen, the nipples can kind of flatten out a little bit. So squeezing it so that it's something the baby can bite onto. And I've noticed if you rub their cheek, they kind of open their mouth like that. And when they open their mouth wide, that's when you want to present the breast to them so that they can try to get as big of a mouthful. If they don't get a strong latch, you'll want to try again, because you want the baby to be able to not be frustrated and to be able to stimulate the breast correctly. And also, if you, your milk ducts, they pull from back here. And so if you want to press like this, you can get your milk to come forward a little bit and maybe leak a little bit, and rub your nipple on the baby's mouth. And when they taste that, they're going to start suckling. It's also a reflex for them to start sucking when something touches their lips. So you can kind of rub their lips either with your finger or with your nipple. Sometimes if they're having a hard time latching, I even stick my little pinky in there just a little bit, so they start the sucking already, and then I switch and put the nipple in. So that's just a little mom tip. And also, something that can help you is if you turn the baby sideways and take off their clothes, and it helps if you're skin to skin too. Not that you have to completely take your shirt off, but if they can kind of have their tummy and face against your bare skin of your breast, turn them this way, and so that their cheeks are stimulated, which again is that reflex that stimulates the sucking. You can try different holds and see what angle the baby likes. You could do a football hold where you hold the baby this way and they're sucking from this direction. You could do the standard cradled hold. You could even forward hold them. But there's lots of different options there. For moms who have twins, you can feed both at the same time, or you could alternate. Most people alternate, and the babies kind of get in a sequence there. And then babies are going to do hunger cues. They're going to be searching. We call that rooting, and they're going to cry. They're also going to, sometimes they like stick their tongue out and they're like, and when they do that, they're kind of trying to suck and emulate that same sensation. So that can be a sign that your baby's hungry. If they're sucking on a pacifier or their hand or something else and unsatisfied with that and spitting it out, chances are they want milk and not just to suck. So there's those tips there. Also, if for breast milk, some tips I have for increasing your supply is feeding your baby often and constantly. And you can also pump in between feedings. If your baby is a baby that waits a little bit longer in between feedings, pumping in between, constantly stimulating the breast is what's going to make your body produce more, because your body is on a supply and demand system. So the more you need, the more it produces. So if your body constantly thinks, oh, I need to make more, I need to make more, I need to make more, I'm feeding the baby, now I'm pumping, I'm feeding the baby, now I'm pumping, body is going to be stimulated to create more milk due to the demand of what appears to be a hungrier baby. And so breastfeeding often. Now, this is exhausting, moms. Like, we're going to be doing this a lot every 2 hours. And if you're pumping in between, it's even more. And I've been there. I felt like I was chained to a wall with my breast pump. There are other options. I know there's a really great pump out there right now called the Willow. I haven't personally had the pleasure of using it as much as I desperately want one. A lot of our surrogates use that who are nursing, or I should say pumping for their surrogate babies, but not nursing them. And it's constantly pumping for you. It's hands-free. You can walk around and do whatever you want. It's in your bra. And we've had some people who are almost completely out of milk who somehow come back to like full throttle lactation with the Willow. So I've heard nothing but great reviews. That's always an option. They have lots of things like lactation cookies and different supplements. I'd talk to your healthcare provider about what they think is good for you and for your infant. Also, if you stop smoking, things like that, those can hinder milk production. Staying hydrated is huge. Drinking a lot, I mean, your milk is a high percentage of water, and so is the rest of your body. And if you're not drinking enough, your body's going to use its water for other things to maintain your body's ability to survive as well. So getting extra water, drinking more than you would normally drink, can aid your milk production. So that's a good one. Your milk will also start to come in when you hear the baby cry. I know after I had my surrogacy baby and the family had their baby, when other people's babies would cry, I would start lactating. It was very weird. So don't be surprised if that happens. Also, sometimes babies need to be burped like mid nurse. So you kind of break them away and burp them a little bit if they're a baby that spits up a lot. And it kind of gives them a chance to settle down too and take a little breather, let them burp, and then you can return them to the breast. Another thing that helps with milk production and with nipple soreness is alternating breasts and switching sides every time you feed, and sometimes within a feeding, which it means both nipples are being stimulated, and so you're trying to get both breasts to produce. It's not uncommon for one breast to produce more milk than the other, so don't be surprised at that. It's also not uncommon for a baby to prefer one side over the other. So it is still important, though, if the baby has a side preference, to still nurse on the other side. And if you have any kinds of signs of mastitis or like nipple inflammation that's really sensitive or infection that hurts, talk to your healthcare provider because that can make it hard for the baby to latch as well. But nursing through mastitis actually helps to make it better, which is unfortunate. But again, just talk to your healthcare provider in that situation. And feeding your baby, it's usually about every 2 hours. So that constant stimulation, like I said, is important. And you don't want your baby to go more than 4 hours in between. Usually we recommend 2 to 3, every 2 to 3 hours, but 4 to 5 hours is too long. After that, you want to wake the baby up. So if your baby is sleeping, waking the baby up to feed them is really important, making sure they're getting their adequate nutrition. We talked about how small their little tummies are, the size of like a marble or an almond at the very beginning. And so it empties quickly and needs to be refilled quickly, and so that their body has the right nutrients that it needs to grow, and also the antibiotics to fight off all these crazy bugs that we got floating around. So nursing regularly is not just important to feed the baby, but important for you and important for their immune system. So when we're feeding baby, there's lots of different positions we can use. One of them is this cradle hold. We talked about the football hold earlier and the wrap positions. So whatever fits best for you and whatever your baby is most comfortable with. And you'll want to alternate sides too and see what's most comfortable in that position. But the main thing I wanted to talk about is that after we feed the baby, it's important to burp the baby so that it doesn't spit up as much and gets the gas bubbles out of their belly, because they are sucking a little bit of air in, whether they're on your nipple or whether they're on a bottle. And so I'll show you what that looks like. And we turn the baby, and we're going to go into this chest position where the baby is supported against her chest like this, and you pat their back just a little bit. You can also kind of cusp your hand like this shape a little bit, and that compression, oh, see, there it goes, works like a charm every time. That helps really well for burping the baby too. Another position that you can burp the baby in would be the position we talked about earlier, like this, where they, are down like this, and you can burp them forward. Some babies like that. Or you can do this on whether supported on your arm this way and burp them like this. Ways to know if your baby's getting enough milk include if your breasts, as they engorge with milk, they'll become harder, and after you feed the baby, they should soften a little bit as that milk pressure is released. So that's a good way to know if your baby's getting milk. If your baby appears to be full and content after feeding, because obviously they'll start to kind of get fussy if they're hungry, and then they should be content after feeding. Then also if your baby has periods of time where they're alert during the day. This sounds weird, but the reason for that is because if they are full and happy, they should have the energy to be awake at some point. And babies who maybe aren't getting enough milk could be overly lethargic and constantly tired and fatigued. So that's a kind of a warning sign there too as well. Your baby will initially lose weight right after birth, but should regain it back within about 10 to 14 days. So we want to see the baby returning to birth weight. We also want to see after a couple days after the baby's born, we want to start seeing that yellowish stool. And so that can be an indication that the baby is getting enough food. After, like I said, about 10 to 14 days afterwards, we want to see the baby return to its birth weight. And then after that, we'd like to see about 5 to 7 ounces gained per week, I think it is, to make sure that the baby is continuing to grow. Do not be put off if in the very beginning you're only making a little bit of colostrum. The baby's tummy is the size of a marble or an almond. So in the very beginning, so it's not much to fill. So your breasts are going to make a little bit for that, and then the baby's going to metabolize it and want to eat again in 2 hours. And then you're going to make a little bit. So it's a slow thing, and it will eventually build up as your baby's tummy gets bigger and bigger. You will start making more and more, and your breasts very much operate on a supply and demand system. So the more the baby needs, the more your body should make. If at any point you feel like you are trying all of the things and you're still not making enough milk, and the baby is showing symptoms that they are constantly hungry or appears to not be thriving as well, you could definitely reach out to a healthcare provider. And I recommend seeking further coaching from somebody who's IBCLC certified. So I want to talk about diapering your baby and changing the baby. In the beginning, the baby will have kind of a really dark, black, tarry looking, what we call meconium, or a dark stool. This is really normal. After the first couple days, it kind of starts to fade to this greenish color, and then eventually around like day 5, it becomes kind of like a yellow seedy color. This is really normal. So don't be alarmed that it's not like your poop in the very beginning. They're not eating what you're eating, so that's part of it. And also, we kind of expect the amount of wet diapers and poopy diapers to kind of, the first couple days to match that. So, you want at least 1 poopy diaper the first day, and the day 2, you want at least 2 poopy diapers, and it kind of follows suit for the first couple days of life. And we do expect them to wet their diaper more than they poop their diaper because they're feeding a lot. And so watch out for that. A lot of doctors will have you track this in the very beginning. And then let's talk about diaper rash. I know that we talked about not using a lot of products like baby oils and baby lotions and sunscreens and all of these things on your newborn. Later when they're older, that's okay, but when they're a newborn, we recommend that not using those products. One thing that is okay to use, and again, like ask your health care provider, is if the baby has diaper rash, and you need to put some cream on it to alleviate this baby's pain, that's okay. But if you're anything like me, I got to the store and there was like 1,000 different things that you need to do. You're like, do I use petroleum jelly, skin protectant, paraben free, aloe natural. This one's like diaper rash ointment. This one says diaper rash cream. Like, do I get a cream or an ointment? Like, I don't understand. The little bullet points, same company, say bullet points say the same thing. Like, which one do I get? This does it in rapid relief. Well, these ones didn't say rapid relief. Does that mean that this one's going to work faster and this one's not? But this one doesn't say that it's, pediatrician recommended to, in every country in the world. It's overwhelming. Okay. Ask your doctor what one they recommend for your baby and let them know so that if the baby doesn't respond well to it, they can recommend a different one. And they know what the baby's being exposed to, if the rash gets worse or doesn't get worse, whether it's actually diaper rash, things like that. Talk to your healthcare provider. Don't just go to the drugstore and overwhelm yourself with lots of different materials. Okay. And then diaper options you can use. There are so many different types of diapers. Again, another overwhelming thing. They have cloth diapers, even they have diapers that are for sensitive skin and diapers that are apparently for unsensitive skin. There was a bazillion different choices. I used the disposable diapers with my children. I do have a couple of friends who have used fabric diapers. It is a chore and it takes a lot of effort, and you'll have to find if you do choose to do childcare, you'll have to find a childcare provider that's willing to also work with with cloth diapers. They can be better for the environment. Also look and make sure that your washer and dryer machine can handle that. And if not, you'll have to wash them by hand. So just some things to be wary of. And I always pack extra diapers and cream and extra clothes in my bag everywhere you go. And the one day that you don't pack extra diapers or clothes, your baby is going to like blow out at the grocery store. So don't make the mistakes that other people have made. Even if you're going to the store for like 5 minutes, I have done that. I went into a photo shoot with my baby for like 10 minutes and the baby exploded everywhere. I had to go all the way back out to the car. Don't do that. Just bring your diaper bag with you everywhere. It's called a diaper bag because the diapers are the most important thing in there. So there's that. As far as wipes go, I recommend getting an unscented one for your newborn. You're not really sure what your baby can tolerate or how their skin is, and it's going to be sensitive in the very beginning. So stay away from the smelly ones, just at least while they're little. And also probably staying away from any kind of baby powder or things like that prevent diaper rash. Their baby's skin is a little too sensitive for those types of products in the beginning. The most important thing to consider when changing a baby's diaper is that they can still go to the bathroom during this process. Anybody who has a baby or has had experience with babies probably has a funny story about getting peed on during a diaper change. So we're going to give you some tips to solve that. So we're going to start by pulling the flaps off to each side like this. And then I like to keep the diaper on nearby and like just elevated like this so that in case there's some spray, the diaper absorbs it. Some people will tell you to use like a little towel or a shirt or something like that. I don't recommend it because then it gets wet and you have to wash it. And with this, you're already going to be throwing this diaper away and it's absorbent, so it's not going to soak and get wet on everything else. So again, we would do this. And I always keep my wipes nearby, and notice I'm holding it with one hand so that he doesn't wiggle and have it come undone. So then I grab a wipe, and when I pull this back, I'm going to kind of shield over the area, and then we'll wipe in the cracks. The babies have lots of folds. I wish it was okay to have folds when you're a grown-up. So wipe in all these little folds, and from the back, and we pull up here and go through, get around their little bottom. And if this was a little girl, we would go from the front to the back. So you don't want to move any of the fecal matter forward where her urethra is. So we're going to go from the front backwards. Okay? And then I put it in the diaper, notice, and I've pulled the diaper away from the baby, and I'm going to tuck it like this. So I'm going to tuck it here, and I'm going to roll it up. And then I use these little sticker pads to close the diaper, and nice and tight to avoid the smell from coming out. Then we're going to grab a new diaper. And so we grab the little diaper, we pull the flaps out first. So the side with the flaps is going to go down underneath the baby. So I hold his little feet and put that long side down with the flaps down. Okay. And then I'm going to hold his legs down just for a second and pull this back over the baby. And these newborn diapers are really great. They have a little bit of a dip right underneath the baby's belly button, and that's because the umbilical cord will stick out for a little while after the baby's born. And then I use these to clip it back up. So you can see this little dip right here underneath the baby's belly button. And that is how we put on a diaper. So I want to talk about dressing the baby. This little guy just spit up, so it's a great time to practice this. So when we have your little t-shirt, there will be a side that has the buttons. You want to have the open side, the shorter side on the front, and then the longer side on the back. And then I like to scrunch the shirt up to create a hole, and then I'm going to go over the baby's head. And as I lift the baby's head, I'm going to support the back of the head with my fingers again, and then pull that opening right over the baby's face. And I try to create a little space when I do that so that it doesn't put a bunch of pressure or, cut off air supply to the baby. So then I also hold the baby's hand and I kind of tuck it into the little armhole, hold his hand again and pull it. They're squirmy little guys, so it's easier if you keep control of their arms. Again, I'm going to grab his little hand and then I put it right into that little hole, grab his hand from the other side and pull the clothing around the arm. Don't pull the arm around the clothes, if that makes sense. And then I'm going to lift him up a little bit and pull this longer part down, and then that will go over the diaper, and we will clip the little clasp in the front. So we've dressed the baby. Okay, and if you look at this baby's t-shirt, you can kind of see that there are little tabs on these shirts, and this is so that if the baby has what we call a blowout, and the baby is either has a leaky diaper or a poopy diaper, you don't want to unbutton the shirt and pull it over the baby's face. We're going to roll the shirt down and take it off the other way. So I'm going to show you that. So we would lay the baby down and like I said, we would unclasp these and we would change the baby's diaper first. But in this case, we will just do the shirt thing. So when you lift the baby up, you can tuck your fingers into these little flaps here, and you can pull the shirt down the other way so that you can go down the baby instead. And this little guy is super wiggly. You're such a good little prop, aren't you? Okay, and I lay him back down. And then as you can see, I can roll the shirt underneath. And now we've avoided moving the poop over the baby's face and we've taken it off this way. And so that's really great. Okay, so I want to talk about how we can bathe the baby. So they sell these really great little tubs. You don't need a tub. You can totally wash a baby in the sink as long as you clean it first. You can even get like a little plastic tub and that would be okay too. I like these ones because they have a drain in the bottom, but there's also lots of crevices you have to make sure to clean afterwards. Try to avoid ones that have really thick spongy material. It's meant to be cushiony and soft for the baby, but they can act like a sponge and hold bacteria, so it's something to be wary of unless you're going to make an attempt to clean it very well every time. So I like these plastic tubs, and this one has like a little seat in it, so that's really great, kind of helps support the baby. So when you put the baby in, we're going to put them against this backrest, and when you have a newborn, see his head just moved. They are very wiggly. So you want to make sure to support baby when they're newborn in the tub. Don't just assume that the tub is going to hold the baby up. You're okay. Okay. And so we're probably just going to fill the water level. Just really low, just so that it's at the bottom of their abdomen. You don't want this tub to have so much water that the baby is going to slip into it and get completely submerged. But you're also standing right here. Never leave the baby unattended in the bathtub, not even for a second to turn around to get a towel. If you are going to turn around, I would hold the baby, make sure the baby's head is supported, hold the baby and grab a towel and return back. Never leave the baby unattended in the tub. So then you would probably use like a little washcloth like this, and you can just dip it in the water. Start from the head down when you're washing baby. So start with their hair, and then you're going to do their face. You can get behind their ears, and you'll go down their arms, into their little armpits, around their belly, get their back. If you need to lift baby forward, make sure that you support the baby front of their head as you wash their back, and so that they don't tip forward into the water, and also to get that head support. So then after you finish the belly and the back, I like to go down the legs and get the little feetsies, and and then, well, actually, before you go to the feet, I would do, if we have a little girl, I'd probably wash around the genital area first. And then I go down, I wash their little feet, and I do their bottom last. And that's because we're going from the top down in order to avoid contamination of areas that are more dirty. So you don't want to take the fecal matter that's on your towel now that you've cleaned the baby's bottom and then wash the face. So you wouldn't want to do that with you, and let's not do that with the baby. So again, top to bottom when washing. As far as what products to use for a baby, for newborns, we don't actually suggest that you use lots of different products like oils and lotions and things like that, or any kind of fragrant soaps. Their skin is really sensitive right now. If you do want to use a little bit of a baby shampoo or something for their hair, that would be all right. I recommend probably a more natural based one, or a water based one. This is the one that I use at home for my newborn. Natural, hypoallergenic. It's tear-free. Make sure to use a tear-free one in case it leaks down into their face. Just because your baby's skin is so sensitive right now with this little newborn. And again, you would just use a little bit of a drop there and kind of wash the hair. I like to block the baby's face so that no water drips down into the face that has the soap in it. Even though it is tear-free, we still try to precaution against that. And then you can have a little cup. Some of these tubs have like little hoses, and those are really great. And you can rinse the water back out of the baby and down into the water. So that's great there. And then when it's time to take the baby out of the tub, we will support baby's head and lift him out like this. And then we'll use this baby towel to wrap baby up. And I will show you guys, see how I use my chin? You're going to come up with all these little things you do as a mom. Okay, and I will show you guys how we can wrap the baby in a towel. All right? So when we're wrapping the baby in the towel, some towels come with a little hood to go over their head. This one does not have a hood, so I'm going to teach you how to do that. So you have a square blanket, you kind of tip it sideways into a diamond, and I lay it down here. And this top of this triangle, probably about this much space, if you were to imagine, is going to be above my changing table here, because that's going to create a little bit of a hood for me. So I'm going to lift the baby. Oh, little guy. Oops. Okay, I'm going to put his head up at the top of this corner, and then I'm going to take one side of the blanket, and I'm going to wrap it around him this way. One side, wrap it around him this way. You're so wiggly. Okay, and then I kind of tuck it a little bit under his back. And then I go from the bottom corner and I fold up like this. And then I take this other side and I wrap it around. And I kind of lift the baby and tuck it under his bottom a little bit. And then I pick him up. The reason for this is so that you can take this little corner up here and rub the baby's hair dry. You can kind of give them a little squeeze, dry them off. Make sure after your baby calms down a little bit out of the bath, make sure you dry off the creases in between their legs really good. Any moisture that gets locked in there, it's just the same as if it was urine. It can give the baby a little bit of diaper rash. So I try to dry the baby really good before you put the baby's clothes back on, okay? So let's talk about a couple of the utensils that you might use to care for your baby. I have these little nail clippers. They usually have baby ones. I can't find mine. You're going to want to cut your baby's nails every once in a while. They are super thin and super sharp, and so they will scratch their face. They'll scratch your face. I usually wait. When they're little, they seem to be okay with it, but when they get a little bit older, they get squirmy. And if you have a squirming baby, you don't want to accidentally cut their finger. So I usually wait till they're in that quiet sleep that we talked about. And I hold them with their back against me so that they're also facing forward. And I cut their fingernails just like I would cut my own fingernails. So I'm not cutting away from myself, if that makes sense, where I can't see how far I'm going. I like the baby's hand to be just like my hand, where I can see exactly how deep I'm going, or if I'm accidentally going to nick their skin, I can see before I make the mistake. So that's a really great tip there. If you were afraid of cutting your baby's finger on accident, you can use a nail file. These come in most of the little baby care kits, or you can use, I like the thin ones because the adult ones are a little bit too thick, but you could use a adult one if that was all that you had. Also, if the baby is sick, let's look at some of these materials I have here. You could talk to your pediatrician about maybe using one of these vapor rubs. This one is kind of like a menthol scent, and it can kind of get the nose decongested a little bit and just loosens up that mucus. But again, ask your doctor about that. And they're going to send you home with one of these for safety from the hospital. You'll want to change this out semi-regularly, because just like bath toys, I mean, you're sucking in bacteria and gross stuff, and it can, and moisture, and mold can grow inside of these. So just making sure to replace it every once in a while. Sometimes it's hard too, like it only gets a little bit at a time. I went to a doctor once and they recommended that I get one of these electric ones. You can kind of see that there's like a sucker on top and some space here, and you hold the button down and it will, it's battery operated, you can take it with you, and it continuously sucks. So it's not like a squeeze, get a teeny bit, squeeze, get a teeny bit. It's gentle, it's not a really strong suction, but it can go up in their nasal cavity and will continuously suck until it gets all of it out, and then you take the cap off, rinse it out, and do the other side. And so that is something I recommend. I use this with my newborn, and well, actually, he was a couple weeks old, but I used this and I preferred it over the sucker. I felt like I had to really like jam this up there to get stuff. So this was an easier option for me. They are a little bit more expensive, but I felt that it was worth it. You can gauge it for yourself. They also might have you give the baby medicine at some point. I've had a lot of different ways of giving medicine. The syringes, most of the medicine comes in these little cups, which is completely impractical for a baby because they don't swallow like with a cup like we do. So I recommend the syringes. You'll also see cups like this that have a nipple on the end so that the baby can suck the medicine out like a bottle. I was given one of those and I found that it wasn't very effective. The baby, yes, liked it, but you can't get all of the medicine out. So all the medicine is like staying on the inside of this and trapped in the nipple because it's kind of thick. And your baby's not getting the actual dose of medicine that it needs. A syringe is great. You can measure it exactly, and you're sucking it up and pushing all of it into their mouth, and you're able to put it kind of past their tongue so that the baby doesn't spit it back out. So sometimes with the bottles or like these pour ones, you pour it in the baby's mouth and they instantly spit it back out. And with the syringe, you can put it behind their tongue so that it kind of like, and they just swallow it instinctually. So that is a great recommendation that I have. Again, let's look at thermometers. If your baby has a temperature, suspected temperature, you're going to want to monitor that. This comes in most of your baby kits, these basic thermometers. For the life of me, I always struggle with these. However, for an infant, they're the best. We recommend that you put it actually rectally is the best way to get a temperature on them using these, and the best way to monitor internal temperature for an infant. You could put a cap on it and also try in their mouth. They have these more accurate thermometers. This one is an ear thermometer. They come with these little caps that go on the end of them, and so you change it out every time. And there's debate over whether these ones work better for. They work better for older babies or older children. The best way for a newborn is rectally. But these ones you can place in your ear. They're quick. They're easy. You press the button and it tells you how hot your temperature is. They have the temporal ones where they go across your forehead. They use those at the doctor. They don't use those for newborn infants. They're less accurate for a newborn baby. So again, using a rectal thermometer is the best option for that. I want to talk about products for babies. A lot of people want to or think that they need to do diaper rash powders and baby oils and baby lotions and things like that. And we actually don't recommend that you put anything on your baby for the first couple weeks of life because their skin is still adjusting to our environment in this new world. And their skin needs to learn how to regulate itself. So your baby is going to have dry skin. Well, most likely the baby will exhibit dry skin initially because it went from being in a constant pool of water to not being in a constant pool of water and being in some drier air. And so their skin will start to dry out, but their body knows to regulate this. And so it will start to make oil. And so that's why you start seeing the milia, the little bumps on their faces and stuff as their body starts to make oil. And their body will learn to supplement now, like, oh, I need to make more and moisten this skin. But what happens if you give the baby lotion and oils and things like that is that the body says, I don't need to make this because I'm getting it from an external source. And so it will stop its own natural production because it's getting it elsewhere. And so then what you see is down the line, if you were to stop using lotion or stop using oil and these products, then the baby's skin is going to get really dry because its skin doesn't know to self-regulate, which is really important for these infants to learn how to do that. Another common thing that we hear about is, or asked about, is sunscreen use. Now, if there is no way to avoid it and your baby is going to be in the direct sunlight, then, talk to your provider about doing some type of like hypoallergenic, natural sunscreen for your infant. But most of the time we recommend it as an alternative to using sunscreen when their skin is so sensitive and adjusting during this early period, is to just avoid direct sun contact for long periods of time. So using like a little summer hat for your baby, making sure the baby's in really light clothing where its skin is protected. If you want to go to the beach, set up an umbrella, sit in the shade. Trying to just protect the baby from those direct rays is more beneficial than allowing them to be in the direct rays with the aid of sunscreen. You really don't want your baby to even risk your baby burning at this young age. It will be painful for them and exhausting for you because it will be uncomfortable and the baby will cry more. So again, just avoiding any products to their skin, a little bit of baby soap in their hair or around their bottom and things like that during a bath is okay, but try to stay away from skin products in the initial couple weeks and even the first few months. So I also have a little hairbrush here. This can be helpful during the baby's bath or every once in a while just brushing through the top of their head like this. Babies can get cradle cap. It's similar to dandruff. The scalp gets really flaky, and trying to brush off that dead skin can help with that. Speaking of hair, actually, your baby might start to get little bald spots. Rest assured, your baby is not aging already. Well, it is, but not hair loss. It's because of the baby's car seat or whatever they're laying down where they're rubbing their head. Their hair is really short and it kind of rubs off and they get little bald spots, and that's totally normal. So don't worry too much about that. And also, I wanted to talk about bottle care. I have this little bottle washer here. So if you're using bottles, these are really great because they can get down in there. These bottles are often really small tops, and you can't get your hand or a washcloth or whatever, and like shaking it is not going to help just with soap. I like to use the bottle scrubber. I turn it down and I clean it out. Again, I replace these every once in a while, just like I would with a sponge, so that they don't get a ton of bacteria in them. And then at the end of them, you can get some that have suction cups so that they don't tip over and get other germs from the sink. And speaking of which, I wouldn't use this on anything besides your bottles. You don't want to get like wash pans and stuff with this, just for bottles. and the ends of them twist off, and there's these little cleaners, and these can go all the way through the hole at the bottom of your nipple of your bottle to get in those cracks and clean them that way. And so that's really a great tool to have there. And make sure that the bottles and things that you get are dishwasher safe and that they're not going to be like leaking some kind of chemical, but most of them will tell you on the box, and most of them are. So let's talk about ways to keep baby healthy and infant illness, things like that. Sometimes sign of illness could be jaundice. If the baby's skin starts to turn a little bit yellow, that can indicate that the liver is struggling a little bit, trying to fight some things off. If your baby is getting dehydrated, they could be really lethargic. They don't necessarily need to be given a bunch of water as a tiny newborn, but they do need to be nursing regularly. And part of that is you staying hydrated as well. If the baby exhibits constipation, for example, if the baby's stool is hard to pass, if the baby is grunting and crying in kind of pain when it's trying to go to the bathroom, or if the baby's poop is coming out in little pebbles, this can indicate constipation for the baby. Call a health care provider, because there's a variety of different reasons your baby could be constipated, and depending on those different reasons, the type of treatment would vary. So I'm going to let you talk to your doctor about that one. Also, keeping the baby healthy, feeding the baby regularly, making sure that the baby goes to routine doctor visits to catch anything that could be preventable. Keeping your baby vaccinated and up to date on those vaccines is important, so that they don't catch anything early on. Also making sure that your vaccinations are up to date. There are certain things that babies can't get vaccinated for until they're older that you could prevent them from getting, and kind of pass some of your immunity onto them too, and kind of create an immunity shield around them. For example, they can't get the chickenpox vaccine until they're like, I want to say, a year old. And same thing with the whooping cough vaccine. A lot of moms, and they recommend not just the moms, but everybody in the household get a whooping cough vaccine, because that's a vaccine the baby cannot get, and could, in certain extreme cases, could be deadly to the infant. So keeping your baby up to date on vaccines, keeping you up to date on vaccines, and making sure you see your pediatrician regularly. If you haven't already signed up for a pediatrician or looked around, they will give you like an on-call doctor that is like the default pediatrician, but you are welcome to look around and read reviews and interview doctors and see which one best fits your personality type or your preferences, or maybe your values. And so I recommend that you do a little bit of pediatrician searching as well before baby comes. So how often is it appropriate to have your well baby checkups? They usually do it a couple days after birth, and then about 2 to 4 weeks after that appointment, and then at 2 months, 4 months, 6 months, and then it kind of peters off after that, and your pediatrician will tell you when they recommend you coming back, depending on the health and symptoms that your baby might be exhibiting. And also, of course, reach out to a healthcare provider if there's an extenuating circumstance, or if your baby appears to be sick. You don't need to wait until the 4-month appointment. Feel free to give your provider a call as soon as the baby starts exhibiting something that's unusual or concerning. Sometimes things might not be normal, and I wanted to talk about when's a good time to call your healthcare provider. So if your baby is refusing to eat, if the baby is like overly lethargic, like they're sleeping way more than 16 to 18 hours a day, and that's very, very unusual, or the baby's consistently not waking up to eat, calling the doctor and figuring out what's going on there could be important. If the baby has a fever, I think it's over 100.4, is considered a high fever for an infant and would be an important time to call. If your baby is constantly crying, now crying is normal. We talked about that. It's baby's going to cry a little bit in the beginning. It's going to get worse, and then it's going to get better. If it doesn't get better, or if the baby is constantly crying and unsoothable, your baby might have colic, and there are things that can help, whether it be medical intervention or natural remedies. So asking a healthcare provider or a naturopath about what to do in a colicky situation is a great idea. If your baby's having like frequent throw up or vomiting or like spit up that is excessive, maybe the baby has a reflux problem. And so reaching out to the healthcare provider for that. If the baby's having difficulties breathing or, really unusual breathing pattern, those would be times to call. If the baby appears to not have good circulation, like maybe it's been, months and your baby, all of a sudden the feet are always blue or the baby has an interesting color to their skin and it appears that their circulation isn't great, reach out to your healthcare provider. If the baby's circumcision site or umbilical cord appears to be infected, call the doctor. If there's weird color changes, if the baby is still like passing black meconium after a couple days, that's unusual, so call the doctor for that. If the baby's having less diapers, wet or poopy diapers than it's supposed to, remember we talked about them wanting to have at least like one poopy diaper and one wet diaper the first day and at least 2 poopy diapers and 2 wet diapers the second day. And following the track, they're going to give you a little reference at the hospital of what you're looking for. And if you're seeing, something that's way different than that, talk to the doctor. So if the baby has really watery stools or really dark urine, things that can indicate that maybe the baby is dehydrated, or symptoms like that. Or also if you find like a slight tinge of blood or pink tone to urine or any blood in the stool, things like that would be a case to call your healthcare provider. And just if you're, feeling like there's something wrong, it's okay to call and find out that everything's okay. And it's better to call than to not call. And call your healthcare provider if you're having a hard time with postpartum depression or feeling like you're unable to bond or that you're sad, because even though it has to do with you, how you're doing affects how the baby's going to do and how you're able to care for the baby. So knowing that it's important to reach out for those things too, because you are just as important and we need you to be in good health so that your baby can be in good health. And this is something that just happens to some of us. And I can relate a little bit and I understand and I've been there. And so I'm extending this out to you because I think there's a lot of stigma around postpartum depression, and sometimes the just hormonal waves. Maybe you're not depressed, but your emotions are up and down. And isolating yourself and not talking about it due to a negative stigma that exists in our culture is a really negative way to go about doing things, because isolating yourself just makes it worse. And sometimes just talking about it, you'll feel better. And if you don't just feel better from talking about it, there are resources and things to help you, and forming mom groups and having other people as a support network to help you, to give you a break, and to kind of get your spirits back up. And getting the help that you need is really important. So that would be the last case that I would say definitely call your healthcare provider. So I want to talk about infant safety. Some of the things that you're going to want to consider are the right type of car seat. There's lots of different car seats. They have expiration dates. There's some of them latch into the car and some of them don't. We recommend that you get one that latches into your car if your car allows for those. Not all. Most newer cars have car seat base latches, but some of the older cars don't. And so learning how to put it in correctly, there are lots of organizations that will help you to learn how to make sure that your car seat is secured safely. We also want the baby secured safely inside of your car seat. So making sure that if it has like some of them have these little shoulder pads. In recent years, I've had physicians recommend that you actually don't have them on there. They're cushy and soft, and they don't want the baby to potentially suffocate from them. So I've heard of taking those off. You could ask your doctor what their opinion is on that. But when you buckle the baby in, there's like the clip that buckles across their chest. You want it to be centered on their chest. Like think about your rib cage here and your bones. You don't want it off center where only this part of your ribs is covered and then the other one's like on their shoulder. You want it over the chest and you want it snug. And you need to be able to fit like a finger in there, but you don't want to be able to like put your hand through that. This is meant so that if the car flips or something happens or there's some shaking, that the baby moves with it not within it. You don't want the baby shaking around. The baby's head needs a lot of support in this newborn infant stage, and you don't want them flopping around inside of their car seat should something bad happen. So keeping them stable is really important. And again, making sure it's up on their chest plate here and that it's snug against them. If the baby is wearing like a winter coat, they actually recommend that you take the winter coat off of the baby, then cinch the car seat down so that it's snug against the infant's chest. And then just replacing, either putting the coat back over them or putting a blanket over them instead to keep them warm in a cold car. Because those things like coats and fabrics can get ripped off in certain circumstances. And now what the baby's thing might have been snug against their coat, but if the coat gets pulled back at all or torn away, now there's all this gap space. So we don't want that. It's not safe for them. So making sure that the baby is snug underneath there. And again, I recommend you either watching some other videos by certified staff or going and taking a class that teaches car seat safety. Also making sure that you don't leave your baby in a hot car, whether the windows are down or not. If the car is hot, you should not leave your baby unattended, and you should not leave them in a car that is super hot. They can suffocate just like we wouldn't leave our pets in a hot car. We also recommend that you get a crib and that or a bassinet or something, or a co-sleeper bed, so that the baby is at a lower risk of SIDS and not sleeping on you or in your bedding where the baby could suffocate. So that's really a great tip. If you're going to use a swing or a bouncer or something like that, making sure the baby is buckled in. In the early couple weeks or whatever, the baby is not going to just like flip out of there. However, it doesn't mean a pet can't bump into it and it tips over. And it doesn't mean that the baby isn't eventually going to start wiggling, and you're not going to know when that day is, and you don't want to wake up tomorrow and the baby's on the ground. So making sure the baby's buckled in, and also if you're going to have pets, making sure that the baby is not allergic or that the baby is monitored when around pets. Even if pets are nice, you still want to monitor them because they don't always know their impact on this little small infant. For siblings, making sure little ones remember to support their head, and that the siblings are also up to date on vaccinations. And we want to promote the sibling bonding, but parental supervision is always a good idea if they are little. For outdoor safety, again, we talked about shielding them from direct sunlight and keeping their temperature regulated. If you're in a hot place, keep the baby cool. If you're in a cold place, keep the baby warm. Add clothes and blankets. And those kinds of things. Again, we kind of want to avoid insect repellents and things like that for a newborn baby. So just keeping their skin protected with clothing if you're in a area that is at risk for bug bite. So I also want to talk about childcare. Most childcare places don't offer infant care until the baby's about 4 weeks older and until your baby is vaccinated. So those are things to be wary of. And you can also, of course, use a family member or something like that, someone that you trust. I recommend looking around at daycares. There are a lot out there. I have looked at a lot of daycares. Some of them are cleaner than others. Some of them are less expensive. Do not make the assumption that just because something is less expensive that it's less quality. I have seen a variety of circumstances, some that were very surprising to me. I have been into some learning centers that have all kinds of animals and amphibians and fishes, and that can be a great learning environment. But if your child's allergic to pets, then maybe it's not. So things like that to consider. Looking at the ratio of kids to providers, that can be important. Maybe your care center offers baby sign language or whatever it is. So interview around, look around, find someone you trust and someone that you're comfortable with. And if you're concerned about level of care, not being able to afford childcare, there are lots of programs available to families in need. And we can list a couple of those in the comments with some links for you. I also recommend that you take an infant CPR class. It is really important to know how to respond to your baby in case of an emergency, whether that be choking, whether they stop breathing, so that you can provide some first responder care before medical teams arrive if necessary. I actually, personal tip, I recommend more than just the mom or bio parent taking this. So anybody that lives in your household or that will be watching the baby, even your kids should take this class. It's a great skill to know, and sometimes you don't know how you're going to respond to an emergency. And some people are hysterical and they're not capable of like collecting themselves and counting the 30 compressions or whatever it may be. So having a backup person there who is also trained in it can be helpful. So that would be my tip there. Thank you guys for listening. I hope that all of you go on to have a beautiful childbirth experience. You're on the right track by taking a childbirth preparation class, and I hope that everything goes as smoothly as possible for you. If you have any tips that you'd like to drop in the comments below, or if you have any questions, I will do my very best to respond. And I also want to encourage you guys to take a further class, continue to educate yourself, look into some post-baby classes and relationship building exercises for parents. And if anything, if you don't take any other classes, join a parent group or a mom group, whether that be on Facebook or like they have an organization called PEPS. And these are really great organizations that get moms together and doing things. I'm a part of a group called Adventure Mamas. I'm sure there are lots of groups like that where you're getting together with other parents, and specifically with PEPs, you're getting together with other parents in your age group or who have children in your age group, I mean. And this is a really great bonding experience for you, and it's a great learning experience for you. And your kids learn to socialize, and it just gives you a little bit of a breather and some relief and some additional support. And that could be different than what your family or friends are able to offer to you. So again, seeking out those support groups is really awesome. And I hope that you guys all have a great birth moving forward.